I'm just trying to sort it out on the background, but I think half of the participants are in one meeting and half of the participants are in another. In that there were 2 invites sent out with different call-ins. So I'm just trying to get to the bottom of which one we need to be on.
I'm just going to hang up.
Hey, Brian, you seem to have figured it out. How did you get on this call?
Is he in both at the same time?
Yeah, he is.
Hi everyone, sorry for the confusion. So we were on the other invite. I just want to see, so we have, okay. Sorry for keep you waiting. So before heading into introduction, so welcome you all for Respiratory Ambulatory Clinic Enterprise Overview session. So before going into introductions, I will go over the housekeeping items. So please mute yourself while you are not speaking, and don't forget to mention your name when you are speaking, so that I can document the proper meeting notes and follow-up items. And feel free to add any non-urgent questions in the chat so that we can have a look later on and can answer. And let me know if anyone has any objections as we are recording this session. And the agenda for today's session, sorry?
I'm sorry. Hey, it's Alex. I'm sorry to interrupt. I just wonder before we totally kick off and get started, can we just confirm that the meeting invite has been sent to everyone we're expecting? Just because I'm looking at who's on the CEC ticket as like confirmed attendees, and they're not all in this call.
Sorry?
So I just want to make sure that the people who are going to be joining this meeting have the invitation for the correct one.
So yeah, this was the correct invite, and this is 11 to 12 meeting. So I wonder like how we are able to join this meeting. Just gonna cross check again.
Okay, so the Skype call in that people should be joining is for the 11 to 12 meeting, right? Because I'll just send a blast out to everyone we're expecting, because there's people who we're expecting to come to the meeting who are not in this call yet.
Yeah, sorry. I just want to confirm the conference ID we are on. Is it 52328249?
I'll double check, but that sounds right.
Yeah, the conference ID is same on both the invites. I wonder like why there are two sessions.
Yeah, the links when you click on the link to join it, it's a different session. So that's okay as long as we get everyone to join the correct one, which should be, I think, is the 11 o'clock invite. I'm just going to check really quick. Yeah, that's correct.
So I see Tila Dawn Bolt here, right? So she has an invite from 9 to 12, but the conference ID is same for both the invites. So the link for the meeting is same. So that's how she was able to join, Tila. And who else is there? Okay, I'm just wanted to confirm if everyone is here on this session. Do we have Lynn Padden here?
Hi guys, this is Tila. So I am the only one here right now. Dr. Badwen and Sheena Kumar, my nurse practitioner and MD, are not available until 11. And Lynn Padden, I believe, called in sick today. So I will be representing everyone.
But Sheena Kumar accepted and we confirmed her availability from 9 to 12.
She's just on the floor. Okay. If you want me to grab her, because I know she's just going in and out of patients, because we still have inpatients to care for.
Okay, before you go, I just want to confirm. Yeah, she is here from 9 to 12.
Okay, I will go grab her. Just give me
Tila.
Yeah?
Tila, it's okay. Let's just wait till she joins us later, and we'll save the questions. I appreciate you being here, though. Thank you.
Perfect. No problem.
Yeah, thank you. So just Tila is here, right? And our providers will join from 11. So is that okay, Alex, to move forward with the session?
Yeah, no, that's great.
Yeah, I was a little scared.
Can we just...
Conference ID is same. Yeah. So yeah, it has 2 invites. So every session has 2 invites, different one for providers because they are joining from 11 to 12. Thank you. So... yeah, agenda for first 10 minutes, we will be going over the introduction and housekeeping. And then we'll go over the CST guiding principles and purpose of session. Then Douglas will take you over the end-to-end workflow, enterprise workflow, and Kristen will go over the enterprise demo and follow-up questions for referral triage, scheduling, and check-in workflow. And then Goran will go over the nursing assessment and documentation. Then we'll have a 10 minutes break. Then when the providers will be here, we'll go over the enterprise demo and the gap analysis for provider assessment, documentation, and follow-up. And the last half, last minutes, we will go over the additional questions if anyone has and what we have on the slides. And then I will talk about the next steps after this session. So I see like we only have Tila. I just wanted to confirm and double check again if anyone else is here. And Tila, you are here as a clerk too, right?
Yes, I'm here basically as everyone right now. I pretty much run this clinic independently, so I should be able to answer most questions.
Okay, thank you. Welcome. And from ambulatory team, we have myself as ambulatory PA and April as application analyst. Our informatics leads are Nicholas, Alexander, and Jack. And our informatics specialists are Douglas, Garin, and Lisa. And from scheduling team, we have Kristen. From registration, we have Celia. And from pet team, we have Fraser, Kalina, and Brian. From lab team, we have Jack and Norma. And from medication team, Tam and Vinny are here. So our CST team members will introduce themselves when they will go over the presentation piece. So I just want to quickly go over the CST design principles. So the guiding principle, our focus is enterprise design. We are configuring enterprise-wide design, meaning we're covering all the 3 health organizations. So in our sessions, we are inviting the life sites SMEs and the future site SMEs. So life sites have valuable CST experience and can help shape the continued design and build of the enterprise Cerner system. And sites that are not yet live can gain an understanding of the CST Cerner design and build processes, and will preview enterprise workflows that are specific to the clinic area. So our must-have guiding principles are...
Duke, sorry, I just want to jump in really quick, just to acknowledge, I think I see Deanna, on the call from BC Cancer. She's one of our clerks from BC Cancer. Is there any other folks from live sites or not yet live sites on the call? Okay, there may be some trickling through. Just thank you for attending. This really is a VGH-oriented session, but obviously you've been using the Cerner system for a little while, so if you have nuggets of wisdom, that's appreciated, and if not, just we can learn about the VGH workflow. Thanks.
Thank you, Alex. So yeah, so the must-have guiding principles are these 4 principles. First is safety, changes that have patients have safety implications, and second one is regulatory. So we are implementing those changes that are required to meet regulatory reporting requirements in national or international standards. The third one is financially, so the changes that would help us to create efficiencies without requiring significant operational cost implications. And the last one is content. So we are doing changes to add content that currently doesn't exist and is basically required. So purpose of this session is to review the enterprise workflow, validate what works, and we will identify any key gaps we have, and we'll review the content that currently exists in the Cerner and validate what content works as is and identify any key gaps or changes which are required. And also we'll gather additional information about clinical workflows, which we think we need to know, and about the key gaps. So we'll quickly go over on this the clinic overview. So respiratory ambulatory unit is a clinic which provides care for the patients requiring urgent respiratory care, including lung cancer, pleural effusions, hematitis, bronchoscopy, including pre and post care. And the clinic visits, visit types in this clinic are telephonic, outpatient, inpatient, emergent, and urgent care. Tila, I just want to confirm all this information which we have here. Feel free to point out if there is something missing or incorrect.
So for everything, it's correct.
Thank you. So
could you just expand a little on the inpatient part? You see inpatients in the clinic too?
Yeah, so basically how the clinic works is we do all of the chest tube insertions for most of VGH. So how it works is if a doctor will bring an inpatient from a different unit to my clinic, we would do the Plerex insertion here or a thoracentesis or what other chest tubes like a pigtail that they would need. And then I would make sure that they're stabilized before I send them back to whatever unit they came from. And they're usually with me from 1 to 4 hours, depending on the severity of the chest tube and what's going on.
Awesome. Thank you. Is what makes up the bulk of what you see? Is it the inpatients or is it a mix of everything?
It is a mix of everything, and any given day I could have 1 to 9 patients. So.
Okay. Yeah. Thank you.
No problem.
Thank you, Tila and Alex. So the roles involved in this clinic are physicians and nurse practitioner, registered nurse, and scheduling clerk. Is there any role we are missing here, which we?
Okay, so the clinic is a little interesting. I am this as a registered nurse. I do everything. I'm the scheduling clerk and the nurse. And then my nurse practitioner really only works with me on Wednesdays for pleural disease day. And then the physicians, we have a rotating list. So they come and do consults with me. Depending on the week, it's a different physician and a different fellow. If that kind of makes sense.
But these roles play like they are involved in the clinic.
They are involved, but the nurse does do multiple roles in this here.
Like doing the registered nurse piece and scheduling.
Yeah.
Okay. Tila, in the questionnaire that was filled out, I don't know if the manager filled it out, but there was a 0.2 clerk.
Yeah.
Can you elaborate on that?
So how it works is because I am an outpatient clinic located on an inpatient unit. So I have 2 unit clerks that run thoracics on T12 for A and B side. So if I'm ever stuck, I do have additional support, but they work technically as the inpatient unit, not in my clinic.
Gotcha, thanks.
Outside my door, so it kind of overlaps.
I see.
Mm-hmm. Thank you.
No problem.
And the clinic days and hours are Monday to Friday, 8:30 a.m. to 4:30 p.m.
Yes.
Is that correct?
That is correct.
Okay, thank you. And the clinic location is Jim Patterson Pavilion, 12th floor, room number 12710-899 West 12th Avenue, Vancouver.
That is correct.
Okay, and the current state application which you're using in your clinic for referral triage are iClinic, Plexia, PCIS, CareCast, and it's on
CareConnect, actually, not CareCast.
Okay, thank you for correcting. And the waitlist, you use PCIS CareConnect, I believe it is, and paper.
PCIS and mostly paper for the waitlist.
Okay,
I don't use CareConnect for that.
It. Okay. And registration?
Is PCIS and iClinic. And also Plexia if we're registering for a bronchoscopy.
Thank you. And for scheduling, it's PCIS, CareCast, and paper.
No, it's PCIS, iClinic, and paper.
Thank you. And for clinical documentation, it's iClinic and paper.
Correct.
And for orders, is PCIS and CareCast.
Orders are also paper because I take like paper orders and then send them to health records.
Thank you. And you view results via CareConnect.
Yes, I do, and PCIS on CareConnect.
And the inpatient results reviewing is done via PCIS data.
CareConnect, and sometimes iClinic also has different things from our sister clinic, the Lung Center.
So you use iClinic too.
Yeah.
And inpatient charting is on paper.
Yes. Oh, and also iClinic. We have informal iClinic notes on a program.
So is iClinic an application?
It is, and it buddies with our sister unit, the Lung Center, which is located in the Gordon and Leslie Diamond Health Center, and it connects with the Spirometry and Pulmonary Function Lab here at VGH.
Okay, thank you for elaborating on this. And the clinic patient admission notification is done via
we
system.
Email out a piece of paper that I have created.
So email?
Yeah, or a fax if they have a fax, but it's very seldom. Or we would just call them over the phone and notify them.
Okay, thank you. And are there any databases you are using in your clinic?
Just iClinic, really.
So iClinic is a data. Okay.
Yeah, we can get all the different lab results, upload everything between us and the lung center and everyone else.
Okay. Any other database you use to track your patients?
Not really.
Thank you. So for reporting, which kind of report, or do you use any application?
So for reporting, we use iClinic for informal chart notes, and then we use the hospital nursing notes, history, and consult papers. And then those are all filed down to health records.
Okay, thank you. Thank you. So I will give, now we'll request Douglas to go over the presentation.
Thanks, Suk. Doug here. So I'm the reminder primary CS on this call here today. So I think for this portion, we just want to do a brief overview of what we're going to go through today as far as workflows and what we have built in Cerner already. So just before we jump into that, here's just a little bit of a legend here so everybody knows what I'm referring to. If you already know about this, I apologize. So power chart is essentially anything you're going to do for clinical charting, checking lab work, all that sort of stuff. So that's clinicians, what they're going to be using, providing patient care. The next is the scheduling appointment book, and that's pretty self-explanatory. It's for scheduling appointments and as well as receiving referrals, internal referrals specifically. And when we're referring to internal referrals or external referrals, internal, we mean anyone that's using Cerner and creating the referral within Cerner. And external, we're referring to a referral coming from outside of Cerner on a fax machine or something like that. So Work Queue Monitor, that's where those external referrals would actually come from and populate. So you can kind of think of it like your digital fax machine. So it would be hooked up to an actual fax machine, and it's just going to digitize all the paper that comes through there and create a list for you within Work Queue Monitor. And last, we have Patient Management Office, which is essentially just a way to monitor what your patient's up to in the system as far as if they're accepted, rejected. So this would be used for creating patient encounters, discharging patients, and seeing where they're at as far as if they're ready to be booked and things like that, especially used during the triage process. So you can go to the next slide there. So this is sort of okay, that's kind of the end-to-end. Suk, you went back to the, yeah. The sort of the end-to-end workflow of what we're going to discuss today, starting from external and internal referrals. So you can see the external one there. The referring provider faxes it over, and like I said, it populates in digital form in the Work Queue Monitor. And then the internal one is going to populate the scheduling appointment book. So the clerk at that point would be creating a referral encounter and setting to ready for screening. And you would do that. You can do that in the scheduling appointment book and as well in the Work Queue Monitor. So creating that referral encounter is what moves this patient referral onto the clinician. So at that point, the clinician can review and screen the referrals. So this one we've built off, this one is kind of a demo of Pacific Lung, which is a little bit more, they have a little bit more of a complicated screening process. So there's a screening, and then it goes back to the clerk, and then it would go off to a specific physician type or a different part of the clinic. Like for the Pacific Lung, it's split into like ILD, asthma, soup. So there's a lot of different, so that's why there's kind of that double screening / triage piece there. But essentially, once the triage gets accepted or rejected by the clinician, that gets monitored in the PM office, like I was saying there, and you can follow patients along in there and see like, okay, this patient's been accepted, and then you would go ahead and book it within the scheduling appointment book. Or if they get rejected for whatever reason, you would go to back to the PM office where you're sort of monitoring that what's going on with the patient and discharge the referral based on the clinician's decision. Go to the next slide there. So all good so far? I will go on to registration, scheduling, and check-in. So on the left there, prior to clinic visit, that's just sort of just recapping that last little piece where the clerk or whoever, I guess in this case, would be seeing that the referral is accepted. They go over to the scheduling appointment book and they schedule the patient. There's a couple other little housekeeping things you need to do there as well, as far as changing the patient encounter from a referral encounter to a pre-outpatient encounter. So in Cerner, we've split up patient care into encounters. So it would be, any interaction with the healthcare system is called an encounter. So that's what we're referring to when we're saying encounter. So this would all be part of one encounter essentially. And on the right side there, we have the day of clinic visit. It's still a similar check-in as to what you would be doing prior, I'm sure. So clerk essentially, I guess it would be nurse in this case, verifies patient information and checks patient into Cerner, and then just updates that encounter again from a pre-outpatient to outpatient encounter and actually gets them checked in, and that'll populate a different part of the system. So nursing physicians can look at the schedule and see, okay, this patient has been checked in for the day. And here is the day of visit assessment and documentation. So this is also the piece that I will be demoing later on in the presentation here. So first, clerk checks in, and then from there on, it's clinician. So the clinician is going to see in Power Chart. So if you remember, I said Power Chart is for like any patient interactions documentation. So they'll go into Power Chart in the ambulatory organizer section and see, okay, good, the patient's been checked in. They can open the chart, review, whatever your preferred order of doing things is, take a look at the patient, assess them, perform any care, I guess in this case, some sort of chest tube, and document that. And then as they leave, if there's any order entry, medication orders, things like that, you can go ahead and do that, and I'll be demoing that as well. And if there is a follow-up appointment, anything like that, you can also enter that into Cerner if need be, and that again will jump right over to the clerk, and the triaging process screening would not be included in that. It would just go right to the clerk for scheduling under whatever timeline you've asked for.
So maybe if we pause there, thanks, Doug. I guess just, in case it wasn't super clear, Tila, what we were just showing you there is sort of what workflows already exist with the CST Cerner world, and how, other respiratory clinics who are on Cerner are using Cerner right now for their workflows. Obviously, this is a very clerical, heavy workflow that we've just shown you. And so we can kind of wiggle a little bit as we go through our, subsequent meetings to figure out how your workflow might look. But I'm just going to put it out there as like a bit of a feeler. I do think that it will be challenging for you to maintain your clinic volumes doing all of the scheduling stuff yourself.
Yeah, that's already an issue on most days, so.
Okay, so no surprise there.
No surprise, no.
Did you have any questions about what we just went through?
No, it all makes pretty much sense to me.
Okay, cool. Somebody on mute?
Kristen, are you there?
Sorry. Yeah, I was trying to find my mute button. Sorry, guys. Sorry about that. My name is Kristen Kogan, and I will be doing the scheduling build for this site. So wanted to start going over the types of referrals. There's two different ways you can receive them. They can be external or they can be internal referrals. The external referrals, like was kind of mentioned already, it's kind of like your virtual fax station. It comes into work queue monitor. Sometimes you'll hear it called VQM. And from there, an encounter can be created, and then the incoming referral or fax can be indexed into the patient's chart. Internal referrals, those come into the scheduling appointment book. Those get generated from Power Chart. It's called orders to scheduling. So an order gets placed for a patient to be referred. It comes into a request list inside of scheduling appointment book, and it gets completed from there. Go to the next slide. So for internal referrals, like I mentioned, an order is placed in PowerChart for a patient referral. And when it comes into scheduling, it goes into a request list like this. And once it's in there and you notice that there's a new referral in there, that's where you can go and you can select by your location to filter out other ones that don't pertain. And from there, you'll select the referral that you need. You go ahead and go to the next slide. And what you'll end up doing is you will right click on it and complete that request to schedule your appointment for that referral. Your external referrals, this is Work Queue Monitor. There's a little bit going on here, but wanted to give you a little more visual for it. So the main thing is that center screenshot is where your work queue is, and any of those external referrals will appear in that list there, in that request list. You can have different order work queues. The screenshot on the right kind of shows that you can have, multiple ones, but typically, you'll come up with the one that you need custom for your area, and we'll make sure that that's added and it's labeled appropriately for you. Once you go to complete a external referral, then the screenshot to the left is what kind of pops up. It's kind of blown out from the center one to show you that you can do your referral package that way as well. And you can go to the next slide. And for the screening and the triaging, so when the internal referrals are received, when that order is placed, the provider putting in the referral, they'll be able to mark an urgency for the patient needing to be seen. And then the clerk can screen the appropriateness for that patient to be seen at the clinic. And if everything that's needed for that request has been provided already. And then the patients, they can be placed on what's called a referral triage list. And then from there, the clinicians, the providers can go in and they can also validate that it's appropriate patient for the site. And maybe the urgency is greater, maybe it's less, they can make adjustments as necessary. Go to the next slide. So as I mentioned, once a referral comes into scheduling an appointment book for an internal referral, you select the one that you need, you right click on it, and you can add your encounter there to complete your request. And go to the next one. And so from there, from an external referral, when you're in Work Queue Monitor, you would search for your patient so you can find them and follow through with that request as well. Once the referral has moved forward and it opens up we call it a conversation. It's basically the questions that pop up when you're completing a registration or a referral or an appointment, things of that nature that are necessary. So from here, you would mark that that referral is ready for screening. And then a referral can be accepted or rejected. So the provider, they can enter an order that will basically either be a rejection or an acceptance of that referral. I think there's going to be a demonstration later, a little more in detail about that process. But then from there, that order, it will automatically update the status. So the clerk will then know that it's okay to go ahead and move forward with it. And the referral status, it can also be like a pending. So if it needs to like hang out on a wait list a little longer because there needs to be more information gathered, or maybe they need to have some more labs or diagnostics come in to make a determination. Go to the next one. Okay. So the inside of scheduling, the scheduling request queue that I mentioned, where those internal referrals come to, most of the information there is used to complete that appointment. So when the referral order gets placed, there's lots of fields that provider can enter. Some are required, some are optional, but the more information, the more details that are there, it does help the clerk out in completing that appointment, and that information does carry forward. And then also multiple resources we can select when we're trying to schedule an appointment. So when you go to schedule your referral and it says that, it's urgent and the patient needs seen within a certain amount of time, so many weeks or something, All of that information is gathered, and when you schedule your appointment, you can use this feature called Suggest, and it'll bring back appropriate available slots for different resources at the site, or one that's specified within that time frame. And then you can also book multiple appointments at once. So if you have patients that come back and you know they're going to come back for like reoccurring treatments and stuff, you can schedule, it's called a reoccurring appointment, and then you can link them together. So when scheduling the appointment, then after we've gone through the whole referral process and we've added in all of the details and everything's been triaged, we'll complete our request. And on the right is inside of the scheduling appointment book. So when you do complete request, it's automatically going to pop it over into what's called the work in progress window, because that's what you're focused and you're working on at that moment. And from there, you can either drag it down to a schedule, or like that suggest button is there as well. You can click that, like I was mentioning, to get certain available slots within a parameter. If there are details that were not filled out on the referral order, perhaps the provider didn't know what they were, they didn't have that information handy, then any of those fields that are required for that appointment to be confirmed, they'll be yellow and indicated with a red asterisk. So once the appointment is confirmed into the system, that resource, it's times reserved, it's saved, and that's the reason why they need confirmed, so that somebody doesn't go out, use the suggest feature, and it looks like that time slot is available. Your appointment details or summary information for that appointment is available on those specific appointments. You can double click on an appointment and you can view all the details that came across from the initial referral order, if it was an internal referral. And then likewise too, you can also print a requisition or a copy of some of the appointment information. If the patient is in person, let's say, and they're coming back for a follow-up, you can actually print that and hand it to them, and it could contain their follow-up information for their next appointment. It could also have, reminders, bring your medical card, any kind of current medications you're taking. And if they're not there with you, you can print a PDF and you can actually email it to the patient. So I do have some questions. I won't lie, it's a little more than a few questions. So,
Kristen, maybe before we...
Oh, go ahead.
Sorry to interrupt. I was just going to say, maybe this is an opportunity to pause. Tila, did that make sense, the stuff we just went through?
Yeah, it does. I think it will be easier when I can get my hands on it and kind of play with it a bit. But yeah, it does make sense.
Awesome. And I'm just curious, you had mentioned that you were doing, I think, some scheduling in iClinic, PCIS, Plexia, potentially. Like, how does this process in Cerner compare?
I think this one's a little bit more complex than ours, because right now all of our paper referrals are just paper. So I upload everything and kind of scan it, whereas this might actually make it a little bit easier, and I might actually be able to get rid of Plexia altogether, or PCIS altogether. So we shall see.
Nice. And when you say scan it and upload it, you're talking into iClinic, or?
Yeah, we scan, and all of our referrals are saved into iClinic. That way I can send them down to health records and I'm not stuck with 900 binders of paper.
Cool. Thanks.
Yeah, no problem.
Yeah, that would be great to get you streamlined onto one platform for that. So
yeah, it's annoying when you're multiple areas, and I'm like, let me book here, and then book here, and then write it in paper. So this will kind of hopefully combine everything.
Yeah, it definitely does help, that's for sure. All right, so we're just going to kind of go through these questions. Some of them, it's more confirming information that we had from the original questionnaire. So for receiving referrals, we have a paper and iClinic.
Yeah.
Okay. And then do you know roughly how many referrals you might receive a week?
So it kind of fluctuates with season. So right now I'm getting anywhere from 3 to 4 referrals a day. So I'm ending up with about 20 by the end of the week that need to be booking. But come April, I'll get like 1 or 2. So it really depends on what's happening in the community.
And are those all new patient referrals, or do you ever have follow-up referrals?
Sometimes it's a follow-up, but very seldom. It's usually all new patient referrals from emergency or from GPs.
Okay.
Can I ask really quick? You said you receive referrals through iClinic. Like, how are you receiving that through iClinic?
So we receive them usually from our sister unit, the lung center. So what they would do is if they got the referral on their end and they triaged it as urgent, so needing to be seen before 6 months, they're gonna just flag me, and then they send me a little email, and then it's already in the patient's chart. So then I just print it out my way and get our team to triage it.
Okay, so lung center flags urgent referrals. They send you an email, and then
iClinic follow thing. It's like a little email message that pops up with the patient's chart.
Oh, cool. So then you just download a copy from iChip, right?
Exactly, and then I can send them a message, be like, "Hey, thanks, I got it."
Awesome.
Okay. And are you able to confirm if that's the correct fax number that you're currently using?
The correct fax number, yeah.
Okay. And is that fax number shared with any other areas, or is that strictly for you guys?
That's strictly for clinic.
Okay. And then as far as the what you receive on your fax line, are you only receiving referrals? Or are you receiving any other kind of labs, diagnostic reports, or anything like that?
You got it. I get the labs, the diagnostic reports, referrals from GPs, any type of communication, sometimes BC Cancer communication. Yeah.
Okay.
It could be a mix of anything, really.
Okay. And then you mentioned that your patient referrals, that you can kind of get them from lots of different places, the GPs and other sites, correct?
Yeah, you got it.
Okay. And then as far as a standard referral form, is it just whatever that the person referring the patient to you is utilizing that they send?
We have a PPO referral form that we do have for the RAU, and then they just download it off of the intranet here, and I have distributed a bunch of copies around emergency and printed them some.
Okay. I think we kind of answered that other question, other documents with the referrals. I mean, because if they're referring somebody, if they had like a diagnostic report, they might include that too, right?
Of course, or like spirometry or whatever they would, or if they had AFBs done, something, anything really.
Okay, that makes sense. And then as far as I know, I talked about when I was giving like the overview of like the triage process for referrals, that you can reject or accept. Does your site, do they ever reject referrals, or are they one that just accepts everything?
So what happens is we get sometimes like COPD exacerbations. We're not really going to deal with that, or long-term asthma, because the patient's had it forever. So we would refer that to the lung center. We really deal with mostly acute urgent issues, but we will make sure that the referral does get redirected to the right system.
Okay. But keep the acute ones. Okay, that makes sense. Do you currently have a process in place for communicating with the patient or the provider about like the status of a referral?
Okay, so yes and no. So if the doctor sends it to me super urgent and I have time, I'll send them a typed up letter that I created, say like, hey, I got your referral. Don't worry, it's in the process. But if it's someone like COPD that's like a 6-week booking, not really, just because I don't really have time to be emailing doctors all day. But I do try to follow up with the patient within 3 weeks of the triage, just to let them know, like, hey, I did get it. You're just booked for a couple of weeks from now. Like, don't worry.
Okay. And what do you do if you receive an incomplete referral? So if it doesn't have all the information that you need, do you send it back?
I will try to hunt down the information I can find via Care Connect or PCIS or something. If I'm not able to get the information, then I will call over to their clinic and let them know that they need to send additional stuff, and then we just try to get it faxed over.
Okay. And then do you currently have a way that you're managing any kind of internal referrals versus the external referrals?
No, it's all just mixed into one pile once it's triaged.
Sheila, what about like the inpatient versus, a community referral? Like, how do you handle those differently?
No, exactly the same way. As long as I get the piece of paper with like the filled out RAU referral form, we would just triage it. Usually the doctors here, if it's internal in the hospital, they'll just call up to the on-call doctor that week, and then they'll just transfer them right over or book it, whatever they kind of decide. And then I just make it work.
Okay, so you're first notified of a patient on one of the inpatient units that needs like a chest tube or whatever via a
From the
referral.
doctor. Yeah, they don't.
Okay.
Yeah. They don't usually send me a triage internal units. It would just be them communicating with the team, and then the team would let me know, hey, we need to book someone from the LB building for this, and then I just make it work.
So you may not get a paper referral. It'll just be like a verbal. Okay.
Yeah, exactly. And then when the patient comes, they'll come with their inpatient chart.
Gotcha. Thank you.
No problem.
So as far as like your triage and screening process, it kind of sounds like there's a lot of perhaps verbal or like email communication with the providers.
Yeah, or like text. We're not very formal here.
And then from that, that's how you determine if you should go ahead and get the patient booked, correct?
Exactly.
Okay, got it. And then as far as the referrals, once you guys receive it, are the providers or are you going through and doing any kind of prioritization, or are you just relying on the referral if it said patient needs to be seen in 1 week, patient needs to be seen in 1 month?
I primarily prioritize. So if I'm getting a lung mass, I'm never going to wait on a lung mass. I'm automatically going to give that to a fellow or redirect that to one of our E-bus bronchoscopist doctors here immediately. With that being said, hemoptysis is also urgent, so we would get them in right away. But if it was, again, like interstitial lung disease, that's something that can kind of wait. So I would read it first, and then I will flag the fellow if needed. If not, I will put it in a triage pile based on the information I have, and then just let them know all of our triages are done on Friday if it's appropriate to do it at the end of the week.
Okay, that makes sense. And we kind of already went over the process for accepting referrals and how you're communicating with the provider, and then you're contacting the patient to complete the appointment booking and confirm that they're available.
And then I would also write all the requisitions. So let's say the team wants to book them for a consult with us, but they would like a CT, some spiro, and some blood work beforehand. I would write all those, send them to wherever, fax them, and then make sure that the patient follows up with all of those appointments prior to the consult.
Okay, got it. That goes into my next question. If they have some like pre-appointment tests and stuff that perhaps weren't done prior to them being referred or anything like that, or if they needed
and then I would fill them in and make sure that they had everything. Like especially for a lung mass, we're automatically going to do a pulmonary function test and then a PET scan with BC Cancer Agency. So there are some things already in place.
So are those phone calls that you're actually making to help get those scheduled currently, or is the patient responsible for scheduling them and then you're just following up to make sure they did them?
I make all the appointments and follow up with them, and then I let the patient know.
Okay.
Or I'll fax it to CT and be like, please call me once you've booked it, and I'll call and inform the patient.
Okay, gotcha. And then also, as far as like when you guys receive your referrals and everything, do you guys have a wait list? So if you don't know when you're going to be able to get a certain patient in, maybe it's something that can hold off a little bit, do you ever put them on a wait list and come back to it, or you just automatically try to get them booked whenever you can?
I kind of get them booked when I can based on the triage. So our triage will say like urgent 1 to 2 weeks, 3 to 4 weeks, 6 weeks onwards. So as soon as I get the time to book the triages, I will book it according to whatever the fellow has put them as.
Okay. We can go to the next slide, please.
I just have a quick question, and I apologize if I missed this. Is there, when you're like getting your referrals coming in and like you're assembling them presumably for the fellow to triage, I had written down that happens once a week, but is there a list that they're going off of?
No,
Or is it
it's
like
just
paper?
a big pile that I give them of all the referral forms.
Big paper file. Cool. Thanks.
Yeah, no problem.
So moving into some more scheduling related type of questions after the referral process occurs. So right now you're saying there's kind of maybe like 80 appointments a month right now?
Roughly, yeah.
Okay. All right. So like I said, some of this information we just want to confirm. As far as like scheduling, like I mentioned earlier, reoccurring and repeating appointments, do you have patients that come back more than for one follow-up, and not just like a new patient and then a follow-up, but maybe come back for like 3 or 4 follow-ups?
Yes. So on Wednesdays, we run something called Pleural Disease Clinic. So we have patients in the community that have Pleurex catheters or pleural effusions that consistently reaccumulate. So we would bring them in every few months to either drain the Pleurex or do a thoracentesis, and they reoccur with us until either the pleural effusion is resolved or something else happens.
Okay.
How do you keep track of
we
this
kind
patient?
of, we kind of touched on this next question already when I was asking about if you book or you help coordinate booking the appointments for the patients for their other areas. But if you're booking their appointments, are you actually doing it in like iClinic or anything, or is it mostly you calling and making sure the appointments got booked by the specific area?
It's me calling, making sure they're booked, and then I inform the patient of the appointment notice most of the time. And then sometimes also I have an emailed appointment notice. If I'm able to get those tests booked before I book the consult, then I'll add it all into my email notice for the patient, be like, you need to show up at these times for these things. Okay, that makes sense. And you guys don't have walk-in patients at your site, correct? No, thank God. It does alleviate some headache, doesn't it? Yes, it does. And then I know we talked about like the referral and it getting accepted, rejected, and being told that, hey, it's okay to go ahead and book this patient. Is there any other way that it's determined it's okay to go ahead and book an appointment, or does it need to come from the provider? It generally comes from the provider, except for bronchoscopy. So if the transplant team is asking, I can generally make that decision myself based on my availability in clinic. So I don't really need a provider because I'm just going to do the prep and recovery. So that's the only time I don't need permission to really book. And I'm sorry, what kind of appointment was that again? That was for bronchoscopies. Bronchoscopy. Yeah.
Can I just clarify for the bronch? So like they're done on a separate unit, right? Like in the bronchoscopy suite?
Yes, so they come to me, I get them all prepped, do all the pre-stuff. I will transport them down to the suite, and then they come back to me post, and I do the recovery for the hour or so that's needed.
Gotcha. Okay, thank you.
No problem.
So you kind of have like a split role there. You're seeing the patient when they first arrive, then they're going to bronch, and then they're coming back, right?
Yes. Sometimes, depending on if we're short, I will also be the nurse to bronch them and then bringing them back, but that's seldom these days. Okay. And I have one more question about that process. So for the bronchoscopy, is that something that you schedule yourself currently, or you contact the bronch area, the suites, and then they schedule the patient to be up there? Scheduling for bronch is actually done by everyone. So we all have access to Plexia. So it's myself, the fellows, transplant team, all the physicians, and the bronch team. So it really depends on just whoever gets the referral first. Okay. Or the go-ahead from the team, essentially. Okay. I'm sure we'll probably end up diving into that a little later in one of our scheduling sessions, but that definitely helps for now. Thank you. No problem. And then we've already kind of talked about after the patient gets approved for the referral, you would contact the patient, get them scheduled, let them know any other appointments, diagnostics they need to get done, and when those are going to occur, making sure that they're making those. What happens though
if do you make appointment reminder calls to them, and also what happens if you need to reschedule or cancel an appointment?
So I don't make appointment calls to them to remind them. I do a COVID screening the day before, and at that time we kind of go over everything together, just if they have any questions. And then, sorry, what was the other part of that question?
What happens if you need to reschedule or cancel the appointment?
So that would be me. I have to figure out how to reschedule them. We seldom don't cancel. The only time we've ever really closed down clinic is if we're short a nurse. But we just kind of make it work.
Okay.
Because basically, if we're even short a nurse, all I would have to do is call over to the doctor, let them know, and then they would basically meet the patient, still do their consult, and then send them on the way. So we try really hard not to cancel anything.
Okay. All right. And then if you have a patient that doesn't show up for the appointment, are you the one that would call them back to find out, why they weren't there? Do you reschedule those no-shows?
I will reschedule them once, and if they no-show on me again, I will email their GP explaining like, hey, you've no-showed twice, and then the referral is just filed away until that patient can call me or the GP gets a hold of the patient.
Okay.
And then if I do have a referral and let's say I can't get a hold of them, the clinic will try calling 3 times over the course of a month. If we still can't get a hold of them, we'll email the GP. If they do not have a GP, then the referral is just filed and uploaded until the patient ever calls us back.
Okay. We can go to the next slide, please.
I have a couple questions about the pleural disease patients, if you don't mind.
Yeah, no problem.
How do you keep track of those patients right now?
Our nurse practitioner, Sheena Kumar, follows up with all of those patients. So generally, we may get a referral originally from the community, or she may get a direct call. We would book them in to do the consult, and then based on what happens with that pleural effusion, Sheena would follow up with them as needed, and the community would also call her if they need us to do any drainage.
Okay, and then if the patient does require drainage, like would Sheena put orders in for you to do the actual drainage, or?
Yes, or she would come into clinic and do it herself.
Gotcha. Okay, thanks.
No problem.
All right. So we already talked about earlier that you're doing the majority of all of the scheduling. Just if you needed some extra help, there are those inpatient clerks that might be able to help you out if necessary, correct?
Yeah.
Okay. All right. And we've already gone over your scheduling systems but you use iClinic too, right?
We do. So I use PCIS for the timing of my appointments because apparently it had something to do with billing when we had originally got the scheduling. But now we primarily all use iClinic for everything else.
Okay. And then as far as actual scheduling appointments, is it just yourself and then those additional inpatient clerks that have access to schedule?
Yes, and Sheena and all of the physicians have access to the iClinic schedule, so they can schedule wherever they are, and it will pop up on my end that the appointment is done.
So the providers do currently have access in iClinic to schedule, not just like view only?
No, they can schedule in iClinic, yeah.
Okay.
But I'm the only one, myself and the unit clerks are the only ones that can schedule in PCIS.
And then you guys aren't using any private secretaries or MOAs because it's yourself and then, like I said, those 2 inpatients, correct?
Correct.
Okay. And then are you doing the check-in process and the registration and completion of all that when the patient arrives?
Yep, that's me too. And then I get them ready for vitals, and then I'll set up anything that needs to be set up, and I do a quick little assessment on them.
Oh, you're a one-stop shop.
Yeah, that's why my manager won't let me quit. She's like, I want 4 years notice.
So we've actually gone over this next question about coordinating appointments with other areas, so we can skip that one. But I know we mentioned that roughly about 80 appointments a month, but how far in advance do you book out? Do you look out in the calendar to place an appointment?
So again, it's based on triage. So it's urgent, I'm going to book right away. But if it's 6 months, I'm going to try to book within 3 weeks of getting that triage, just so that the patient doesn't get anxious. But it really is based on when I have time in clinic. Some days it's slow and I can do lots of booking. Other days there's not a chance.
Okay. All right. We can go to the next slide. And then kind of just any outliers in your current scheduling process besides having some multiple systems and a lot of paper, it sounds like. But is there anything different about your workflow that you can think of? I know that mentioned the pleural disease patients are on Wednesdays.
No, that's kind of it. And then just like I said, majority of triages are done Fridays by the fellows when they have time.
Okay. Is there anything that with going to the Cerner scheduling that you're looking to enhance or to address from anything that you have going on right now? Is it just getting down to one application?
Yeah, basically, or even two. I don't think iClinic's ever going to go anywhere because I don't know if the lung center is going to become Cerner because they're private. But yeah, even just having 2 applications, that would be great. Get rid of the paper book.
Yeah. No, I understand that. Okay. And we already talked about confirming appointments. You call the patient. But as far as like virtual health, do you guys do some telehealth or Zoom visits?
We do, but it's only for urgent consults. So a lot of the times, bone marrow transplant patients or with leukemia, they can be all over the province and they require pre-transplant workups. So with that being said, I'm not going to get someone from like Fort St. John to come down for a consult. So the team will do a televisit that way. And then I would book the spiros at whatever hospital is closest to the patient or an x-ray or whatever the things that we needed.
Okay. No, that makes sense. And then also for the different providers, it looks like they're, 2 hours is pretty standard for a new consult.
Yeah.
As far as like their follow-ups, does
So
that
all
time
the
vary?
follow-ups are actually done at the lung center, our sister unit.
Okay.
Except for pleural disease patients are brought back to us.
And how long are those appointments?
Sorry?
How long are the pleural disease appointments?
Okay, so that depends. A pleurix catheter insertion could be anywhere from an hour to 4 hours. And a thoracentesis is roughly about 2, depending on recovery.
Okay. Okay. Let's see here. And okay, so that takes care of that slide. So we can go ahead and go to the next slide, please. And then as far as like when the patient arrives, are they currently filling out paperwork when they first get there, or are you sending it in the mail to them? Are they getting it electronically?
No, there's no paperwork for the patient to fill out here. So what they're going to do, okay, except for bronch. So a bronch would check into admitting and then they bring the paperwork upstairs with them, such as labels and the discharge sheet. But for a consult, they just are going to check in at the desk with me and they just show me their ID and then I just get them to sit in the chair and then I will get their beds ready and then start their vitals and all of my stuff based on my availability.
Okay. And then also, is there any kind of, do you prep any charts or any paperwork prior to the patient arriving for their appointment?
I do. I make a chart for all of our patients. So it's a paper chart. And how it works is I will have nursing notes in there for me, a consult note and a history note for the fellow or the doctor. And then I have the full referral and then any of the things they had done, such as the spiro results or chest x-ray or CT results, all ready to go. And then they use the paper chart during the consult. They take their notes. And at the end, I would upload it into iClinic, any additional requisitions we're sending off, and then everything will get filed to health records at the end of the day. And we make a little note in iClinic what happened in clinic, essentially.
Okay, so you're like a mini medical records too.
Yeah.
All right, so we kind of went over that process as well. I know we talked about wait lists, but this is a little separate than a wait list. Are you tracking electronically in any way? It could be an Excel or Word document, but just the database of your patients that are part of your site?
Yes, so that would all be on iClinic.
It's all in iClinic. That's where that's being tracked? Okay.
And we can see who we've seen, how long we saw them, and then what we did during that consult or procedure.
And we already talked about the paper charts, so obviously we know what that answer is. And then we talked about everything gets uploaded to iClinic afterwards. Is there any of that documentation that needs to be scanned in color, like if there's any diagrams or pictures,
No,
or
none
is
at
it all okay to be
Everything's
black and white?
We're okay.
All black and white? Okay. And I guess a little more specifically, even, do you ever include pictures of anything?
Only for bronchoscopy patients. So a lot of the times in bronch, they'll print off a page of what their lungs look like, and then I would just put that in the chart and we would file it to health records, or the patient would take a copy home.
Okay. Hang on 1 second.
No problem.
Okay, we can go to the next slide.
I did have two questions just before we move on. When you say about patients not needing to fill out any intake forms or questionnaires, is there any COVID screening that's done?
Yes, but I fill that out over the phone the day before, and then when they arrive, when I sit them in their room, I will also do another quick check, but that's my documentation.
Okay.
Yeah, she doesn't do appointment phone call reminders, but she calls them the day before for the COVID screening to answer any questions and stuff as well.
Awesome. That's good. And then I'm just curious, when it comes to iClinic, like you had mentioned that for some of the documentation, the paper documents that are getting generated, those are being scanned into iClinic as well as being sent to health records. Did I have that right?
Yes. So any
Okay.
consult note that, let's say we're referring to internal med or something, I'm going to upload that in clinic. That way, once I file it to health records, I don't have it anymore. But if it goes missing, and let's say my sister unit, the lung center, is going to do the follow-up and they need it, they have the original document still in the computer. They can just print it and refax it.
Okay. Do you have any thoughts about that process, like as we look to transition to Cerner? Because there will ideally be less paper, and some of those documents will live in Cerner. So I'm not sure if, I guess we'll have to tease out whether it's required to keep putting stuff into iClinic or not.
Exactly. And then if we're able to actually track it on Cerner, do we even need iClinic anymore would be the question, except for communication with the lung center.
Yeah, for sure. Okay, thanks.
No problem.
And then the check-in and the registration process. So once the patient's gotten there and everything is ready to go, when they get there the day of their appointment, they're gonna present. And when they're checked into Cerner registration, then I was gonna say the clerk, but that almost sounds so impersonal. You're gonna confirm their demographics and any other information that you need to. Once you do that and you check it in, that encounter, it gets flipped from like the pre-outpatient or the pre-reoccurring to be an active encounter, to either reoccurring or to an actual outpatient. Do you guys use armbands?
We do. So if the patient's going to bronch, because I'm transporting them in the system with a porter, they need an armband. Or for pleural disease patients, I will collect blood post-thoracentesis to compare. They would need an armband for that too, because lab needs to confirm.
Okay. So do you currently just give every patient an armband?
No, only the ones that
Only
actually
those-
require it.
Okay. And so once it's done and that encounter gets flipped, then that's when that notification happens inside of PowerChart, which again is going to be for yourself, that the patient has been marked arrived and they've been checked in the system. So we can go on down to the next slide. And then.
Thanks, Kristen.
Yeah.
Lauren, are you here?
Yes, does everyone hear me?
Yeah.
Perfect, perfect. So, hi Tila, my name's Goran. I'm a clinical informatics specialist working on this clinic to help set it up for Cerner Go Live. Now, I was going to do a demo of nursing documentation and assessment available within Cerner. Then I was going to ask you some questions. And I know that we've been talking for about an hour and 15 minutes now. Did you want a break now for about 10 minutes?
I'm good. Most days I don't break at all.
Okay. So how about I go through the demo and then we'll, before I start the questions, we'll all take a collective break after the demo.
Perfect. That sounds great.
Okay, sounds good. So the program in Cerner, or the tool in Cerner that you'll be using most likely is called Ambulatory Workflow, and this will allow you to see if the patients arrive either physically or in the system. And this ambulatory organizer has the same assessment steps as you would do without an EHR, such as checking orders, labs, completing intakes form, checking document vitals, head-to-toe assessments. Documentation itself will be clinic and task specific, and you'll typically use PowerForm interactive view, which we call iView, or dynamic documentation. If we could just go to the next slide, please. Perfect. So this is a little snapshot of what the ambulatory organizer looks like. And I'm just actually going to present my screen, if that's possible, and show you a little demo within Cerner. So 1 second here while I set that up. Okay. Now, is everyone able to see my screen?
Yes.
Yeah.
Perfect. Okay, so this is the ambulatory organizer page within PowerChart. It provides a simple but comprehensive display of scheduled appointments. It gives you the provider information here. If you hover over the patient's name, you get some basic demographic information that pops up, gives you some details of the appointment, and then it also allows you to change the status of the client by clicking here. So if they're in the room, if they're being seen by a clinician or seen by Allied Health, this is all information that can be indicated here. And in order to find the patient that you'll be working with on that day, you'll have to indicate the resource group here. And the resource group is defined as a group of providers that provide the same medical services in one or more ambulatory care locations. So if we go into the patient chart here, typically what you're going to see, and the pop-up didn't come up for me because I already opened up the patient chart, but you're going to have to assign yourself a relationship for the first time you access any patient chart on your shift within CST Cerner in order to establish a relationship. And this is the best practice when logging in, is to access the patient from the ambulatory organizer. And then it allows you to establish a relationship with either a nurse or a provider or a consulting provider, whatever your role might be with the client. Now, it's best practice to access the client or click on the patient's chart from the ambulatory organizer, as opposed to going up here through the search bar. And I believe Douglas mentioned this earlier about the importance of encounters. So if you access the patient through the ambulatory organizer, you know you're going to be accessing them at the correct appointment date and time. So you're going to be documenting on the correct area and the correct encounter. That way, no information is missed or potentially documented on the incorrect encounter. So once you open up this page here, you get a lot of information all at once, but the main tab that you'll be working with is the ambulatory workflow tab here. And then the ambulatory workflow is basically located in the menu bar, which is essentially very similar to the color dividers within a paper-based patient chart. The ambulatory workflow itself looks much like a Cardex would. So first off is the toolbar up here. The toolbar up here is where various tools are available to you for use for yourself throughout the clinic. So if you need to do some power forms, you can click ad hoc or some medication administration. There's available to you here as well. And then the banner bar up here contains demographic information, such as the ability to check if there are any allergies active on the patient file, some demographic information, and allows you to double check the encounter type as well, so to make sure that you're on the correct encounter here. And then we also have another important button here. It's called the refresh button. So this allows you to make sure that you're working with the most up-to-date information. So if an order has gone through and you've initiated it, make sure to refresh after to ensure that you're working with the most current information. And this means that because you're going to have various clinicians all accessing the same chart, so by refreshing, you're all working with the most current version of that patient chart. Now, once you get into ambulatory workflow, you have various different tabs within the workflow that you're able to access. So you're able to enter the reason for the visit, the chief complaint here. You're able to access history, such as family history, social history, procedure history, something perhaps they've had some sort of chest tube insertion in the past, and this will be listed here as well. And then with regards to documentation here, so there's a few different areas within PowerChart where you'll be able to document patient information. So if you click on documentation on the left here, and you click on this tab, it takes you to a section called Interactive Eye View. So in this area, you'll be able to go to one of these tabs, perhaps assess, breath sounds, mobilization of secretions. If you wanted to do a set of vital signs or COVID-19 screening, this is all available here. And then you would just right-click here, add a result, and you'll be able to, for example, indicate one of these. Say they have a loss of appetite. Perhaps a household member with symptoms, or they had a support person who's asymptomatic. And then if you want to document some of that information, you would just go up here and click on the green chart and sign. So that's the iView section where you're able to document information. And this information will all feed into the results view as well. So if you're able to refresh here, and you're able to take a peek in the results view of certain assessments. You've done the COVID-19 screening, you've done some, you've assessed the respiratory rate as well. So this is all information that feeds into the results review section. So going back to ambulatory workflow and the documentation section, you're also able to access commonly used power forms. So if you go up and press this tab here, you can, for example, click into ambulatory adult assessment and document in one comprehensive way some general information, how they arrived, who they were accompanied by, problems they have reported to you, different than diagnoses, of course, allergies, meds, histories. You can do a pain assessment, different types of measurements, and then you can do different types of pain assessments as well within this form. So, for example, if we went into here, let's say we added some information that they smoked. We would click the green check mark after we documented here, and this form would be available for you to view. Once it's refreshed, you can go into the form section here to take a peek at that ambulatory adult assessment you just completed, and you're able to right-click and do some modifications or uncharting based on whether that needs to be done or something, maybe perhaps you missed some information you want to add. So that's the ambulatory workflow, and it sort of centralizes a lot of the information that you'll need to work with. And then the last thing I'll show you today will be the medication administration record. So this is what it looks like. So this patient here has rivaroxaban ordered POVID with food. And then this medication will be administered twice a day with food. If this is, for example, a patient that could be an inpatient where they would get meal trays. And then this would be used with what's called the closed loop medication system. And then the closed loop medication system would involve scanning the patient, scanning the medication to ensure that it's a safe patient practice. Okay. And that's all the information I have to share with you. I just want to share with you a quick overview of PowerChart and how you'll be using it in the future. And then the last thing I wanted to say is this just about the medications themselves. So the medications are ordered by the provider, either as a single order or part of what's called a power plan with various medications. Medications can be activated through day of treatment power plans, and like I said, medications will be given via the closed loop process using the medication administration wizard, which involves scanning the patient and involves the tool that's indicated in the toolbar. All right. Any questions before we take a break?
No, it seems pretty straightforward, but again, I just have to get my hands on it to kind of play with it.
Yeah, absolutely, absolutely. So it's about 10:26 now. Shall we agree to come back at 10:36? Is that good for everybody?
That works for me.
Okay, so we'll see everybody back in about 10 minutes.
Thank you.
All right, we'll just give people another minute or two to come back. Okay, are we ready to proceed with the questions?
Yep, I'm good.
All right, everybody else on the call is also good to go?
Yeah, go ahead.
Yep.
All right. So the first question we have here, the day of visit. So where does the patient go when they first arrive to the clinic?
Our clinic is divided into 2 areas. So we have a little sit area on the right-hand side of my desk, and then 3 beds on the left-hand side. So I just get them to sit for a little bit till I get the bed ready.
I see. So it's a very small unit, like 2 rooms and a sort of a front entrance.
It's no rooms. It's one big clinic with curtains and 3 beds.
Okay. And then the next question we've pretty much answered. And then you will be the first point of contact with the patient in your clinic.
Yeah.
And then we touched upon this earlier, and just correct me if I'm wrong, it's describe your patient check-in process. You check the patient into schedule an eye clinic, and then you do a head-to-toe assessment in vitals. Is that correct?
Correct.
Okay. And then the provider is made aware through call or text.
Yep.
And you do not do walk-ins, but you do book last-minute appointments for any add-ons. Is that correct?
That is correct.
And that just depends on which physician and level of urgency.
You got it.
Okay. And do you have any specific intake documentations for patients to fill out?
No, not really. The only form that a patient ever fills out for us is for pleural disease days. They would have to just sign a few palliative care benefit forms.
I see. And you have those forms in your unit.
Yes, and then I would fax everything off for them.
Oh, okay. Perfect. If we could move on to the next slide. Right. So in terms of who updates health history, for example, immunizations, that would be yourself.
Yep.
Reviewing the chart prior to the appointment, yourself as well. And then we've already touched upon the external documentation systems. Is there a routine follow-up interval?
Not really. It really depends on what they were consulted for, but most doctors try to see the patient at the lung center follow-up within 3 to 4 months.
Okay. And then it would be yourself who books that potential follow-up visit.
Yeah, I would call over and book it.
Okay. And then once your patients completed their visit to your clinic, what is their patient departure process?
So let's say the patient had additional testing booked. I would give them all of the requisitions and information, a card to the lung center for follow-up, and then they are basically allowed to go after that, and then I would just check them out of iClinic and so forth.
So basically, when the documents are given to the patient upon departure are the requisitions and a lung center card.
Yeah, or a prescription if they had given them a prescription for something.
I see. Okay. And does the patient provide, or do you provide with any educational materials as well?
Yes, so if we're doing bronch, I would go over the whole bronch process for them and the booking and how they would get to daybed. And then for pleurexes, we do some teaching regarding how you would do drainage at home, and we usually have a family member that comes in and we can teach them.
Oh, okay. So so on those visits you try to book in a relative as well or a friend to help.
You got it.
Okay. And then with regards to the forms that you use within your unit, is there a number of standard forms that you use on the unit?
Not really, just the standard forms are my nursing notes. I just chart everything that way. And then the doctor uses a history sheet and consult notes. And then everything else is basically just verbalized through or eye clinic. Or
Oh, okay. So if, for example, like with some of the other clinics I'm working with, we get like a compilation or like a group of forms that the clinic most utilizes most often.
Oh, yeah. So that would just be our referral form, really. And then we do have standing PPOs for bronchoscopy, thoracentesis, and pleuric chest tube insertions.
I see, I see. And are all these would these forms be digitized? Like, are they available online?
They should be. They're all available through Vancouver Coastal Health internal system. You can just download them.
Oh, okay. So if possible, after this meeting, would I be able to perhaps email you and get a list of these forms or even a link to them?
Yeah, I can do that.
Okay, fantastic. Thank you. So, like,
you don't use any checklists or anything like that.
No, not really. The only checklist is like basically the COVID screening where I check it off.
Okay, so if you're taking vitals, let's say, 15 minutes, I don't know what makes sense, 30 minutes, 1 hour post something
Yeah,
inserted.
I would nursing note it all and write out the full documentation for that.
Okay, when you say nursing note, like it's just like basically a blank piece of paper where you're writing like a progress note?
You got it.
Thank you.
Okay, and speaking of these forms, this is where you typically document vital signs, histories, allergies, home meds.
You got it. And then anything we're doing during the procedure, what we prep them with, the lidocaine used, etc.
Oh, okay, that's all on these nursing documentation sheets.
Well, that's all on the nursing form that I would hand write out. It's not a pre-done sheet.
I see, I see. Okay. If you could briefly describe your clinical nursing tasks in this clinic. We already mentioned the head to toe with the check-in, with the vital signs.
Okay. So for pleural disease day, I drain pleuric catheters as the nurse, and I do teaching and dressing changes for those. So for the thoracics portion, I pull chest tubes. So I do large bore and pigtail chest tube removals, and then I would monitor them, send them for an x-ray. For bronchoscopy, I do prep, recovery of bronchs. For pulmonary hypertension patients, I do IV insertions, and then I switch their carapul over, and then I do monitoring for them. I basically do anything that's required of me.
I see.
Yeah.
And then would those any special assessments within theirs?
Not overly special assessments. I also prep for all of the procedures and set up all the sterile fields for all of the doctors.
Oh, okay. And do you use any scales, or are you measuring weight?
No scales, no.
Okay.
We do use an ultrasound though, occasionally, aside from my vitals machine.
Oh, okay. Yeah. And do you perform any point of care testing, glucose, urine dipstick?
Glucose for bronchoscopies if the patient is diabetic, but that is it.
Okay. And do nurses or yourself use your own slate schedule during the clinic, or is it shared amongst the clinicians involved?
We kind of have a paper slate at the moment, or iClinic. So if they don't check iClinic, they come into clinic and just kind of check what the day looks like.
Oh, okay.
Yeah.
And you don't call patients in between clinic visits?
No.
To follow up or anything? Okay.
No. They do call me occasionally, but yeah, I don't make it an effort to call them.
I see. And then if they have any concerns in between visits, they communicate to the lung. They just call the lung center.
Or they can call me. I give them a card also for me if they do have concerns. Sometimes the lung center isn't quite familiar with them yet because the consult there might not have been booked yet or the follow-up. So they have multiple resources.
Okay, good. I think we're ready for the next slide, please.
Can I ask a couple of quick questions, if that's okay? You had said that you helped set up like prep for procedures.
Yeah.
What's the process, I guess, for getting like, a tray and some sterile supplies?
So it takes me about 10 minutes. I have to run around the unit. So basically it depends if you need a chest tube equipment. So you need like a tray, your tubes, all of the lidocaine, all of your sterile gowns, gloves, normal saline, all of your tools, such as like your scalpels and stuff, and all of the proper needles. And then a Plerex takes a little bit more for prep time. A thoracentesis is a little bit easier. And then we would also do just regular chest tube insertions also. So it depends on the doctor. Yeah.
Okay, for the trays and like scalpels and stuff, are those just ward stock items or do they come from somewhere special?
I do order my own scalpels, but the trays themselves come ward stock on the unit.
Okay, and do you have like a bulk order of scalpels or is it special per procedure?
I have a bulk order that the people or the inpatient people order for me, and then I just store them in clinic.
Okay.
Yeah.
Awesome.
So
and then I guess I was
ward stock in here, except for the chest tubes we order individually.
Okay.
Yeah.
So what is that process like? Like if you have to insert something and you don't have the equipment?
I would just steal it from inpatient. So I basically just go outside the door and grab anything I need from the supply room.
Okay, but you said that you ordered them specially.
Yeah, so we order, Plerex catheters specially, and then the Plerex adapters and something called pneumostats are all ordered through our own budget.
Okay, but you just like order a box of them at a time is kind of what you mean?
Or like how many I think I may need, like 5 or 6 for the next month.
Gotcha. Okay. No, that's awesome.
Okay.
And then just in terms of like all the procedures that you were listing, I'm just curious if it would be possible to send us just like a sample of some of the things that you typically document, maybe along with links to those forms. Like I think Gordon is going to reach out just so we can do some cross-checking in our Cerner system to make sure that we have spots for all of the things that you
And then I did forget to mention, for a bronchoscopy, they do have their own specialized nursing form that I do fill out aside from the nursing notes.
Okay.
Okay, I can send samples.
Thank you.
Okay. Thank you. If we can go to the next slide. All right. Next question here. Are medications administered in your clinic? If so, are these word stock prepared by a pharmacy or patient supplies? Looks like we have some information about this. You do administer alteplase on glove chest tubes or pain meds prior to tube insertion, correct?
Yes. So all my medications are generally ward stock, except for nebulizers I carry myself, but they are provided by the ward. Yeah, and we generally don't give much medications in here. It would be Tylenol or Ativan before a chest tube insertion, alteplase to end block, and then occasionally we give factor 8 before a bronchoscopy.
Okay.
Yeah.
And then
and everything comes from pharmacy here at the hospital.
When you say word stock, is it an Omnicell?
You got it, yeah.
Okay, thanks.
And then is the administration of this medication, is there a paper MAR you document this on?
No, I would document it in my nurse's notes, and then I would make an order form and an allergy sheet from the hospital paperwork.
Okay. And you mentioned earlier your clinic does use pre-printed order sets, is that correct?
Yeah.
Okay. Do providers commonly order diagnostic tests, lab, MI, cardiology diagnostics to be completed in the community?
Yeah.
Okay. Is the patient asked to use the hospital laboratory for any specific tests?
So Yes, on pleural disease days, the hospital lab would come up and draw blood work, or prior to them coming in, they would just go to the Diamond Center and get their blood work drawn, and then they come upstairs.
Okay. Okay. And then it's either the lab before they come upstairs that collects it, or it's yourself that collects it.
Or I'll call. We have a deal with our lab dispatchers here. They'll come and collect it for me because technically I'm not supposed to collect blood, even though I'm qualified for it.
Oh,
Because they don't have PICC lines, so.
I see. So you get the lab to support you with specimen collection for blood.
You got it.
All right. And then in terms of medical imaging on site, we indicate here that you do ultrasound diagnostics in clinic.
Yeah, and then all of our patients would go to our inpatient chest x-ray department for radiology or the CT inpatient if we require that.
Oh, okay. And this information's all, when someone goes down for medical imaging, it's all documented on the nursing documentation sheet.
It is, and then I would have the requisitions filled out and fax those over to our inpatient departments.
Okay.
Can I just ask really quick about samples, like non-blood samples?
Yeah.
If they're pulling some fluid off of a drain, would that ever get sent down?
Yes, I would pull the samples and then I prep all of the samples and put them into transport tracking appropriately.
And does that go with a requisition?
It does.
Okay.
And I print all of my requisitions off of the inpatient PCIS.
Okay, thanks.
Okay. So the next question here is, what is the role of the nurse practitioner in the RAU?
So my nurse practitioner, Sheena, she works independently and runs the pleural disease clinic. So she basically has Wednesdays in here with me for the full day. And then she may book pleural disease patients sometimes during the week, depending on what their availability is. But it's always to do either a follow-up regarding pleural effusion or a pleurax or a thoracentesis, essentially.
Oh, okay. So they're just in 1 day a week.
Yeah, and then she may pop in whenever she needs just to book in like additional patients based on urgency, but it depends on what her schedule is and the MD's schedule.
So would she ever follow up with a patient on a different day other than Wednesday?
Yeah, she could, yeah.
Oh, okay. So it's pretty fluid as to when
Exactly.
Okay.
It's up to her what she kind of wants to do. And then she would just communicate with me when she'd like me to book them, what she needs, etc.
Okay, perfect. All right. That was the only question I have for NP on my end. Anybody else with any questions with the nurse practitioner while we're here?
Yeah, Goran, thank you. So this is Sirka. I have a question for Tila. So about the in-between clinic visits, you mentioned that patients call for their concerns sometimes. So do you document that, and how do you communicate it to the provider?
So I would document it in iClinic under just chart notes as a quick patient called clinic, referred to this. If I can deal with it, I would just deal with the problem myself and I don't bother the provider. If it needs to be brought to the provider, I would call the provider directly and then inform them. And then either the provider would call the patient back or I would call on their behalf.
Okay. Thank you.
Hi, it's Norma from Lab. I just had a follow-up question regarding the lab work where you have that agreement with lab dispatchers to come and collect.
Yeah.
So I just wanted to clarify, so each time blood work's required, that you initiate that by a phone call to the lab, is that right?
So the first I would put it into PCIS as an outpatient profile. And then I would order the labs that I require, and then I would call down to dispatcher and ask them to come draw in clinic.
Okay, and is that usually required urgently then, within 60 minutes for that blood work to be
within
done?
Within 2 hours, so I can order it as regular blood work, and it's only required post-drainage, so on pleural disease days for thoracentesis for comparison to fluid samples or for pleurax drainage.
Okay, thank you.
No problem.
Okay, I think we're ready for the next slide. I believe.
Um, yeah, so providers will join us at 11. We have 5 minutes. Tila, do you have any concerns or questions you would like to
No,
ask?
so far this looks really good. If you'd like, I can just step out and grab Sheena. She's just on the floor.
Okay, sure.
Okay, I'll just be right back, guys.
Thank you.
So let's wait for 5 minutes, 4 minutes to for providers to join.
Okay, Sheena will be here in about 2 minutes. She just has to degown.
No problem. Thanks, Tila.
Tila, just one second. I had a separate question. Can I just confirm your email address here so I can reach out to you? Is it what I have here is tiladon.bolt@vch.ca?
You got it.
Okay, perfect. Thank you.
Not a problem.
Just curious, if you're sick or you're on vacation, what happened?
So I have a backup nurse, Austin. So how it works is I'm also the main nurse for bronchoscopy here. So I'm rolling out CST for bronch too. So we rotate. So if I'm in clinic, Austin's in bronch, and then vice versa. If one of us calls in sick, either they close clinic or they try and get replacements for us, but it's always a disaster. So if you know any nurses, we are 3 short.
Oh man. So Austin does all those scheduling and stuff just like you is, right?
She does, but I would do all of her training. So she's my second, but I'm basically the main nurse for both departments.
Okay.
Yeah. We also have Rosemary too, but she's retiring before CST rolls out.
Ah.
Yeah.
Seems to be how it happens.
Yeah, I think they plan it that way, so they don't need to learn it.
You've been really helpful.
Oh, good.
If you have other questions, or I mean, if we have other questions, is it okay if we shoot an email sometimes?
Yeah, it's not a problem. Or you can even call me in clinic. I am here every day.
Amazing. Thank you so much.
Not a
Hi,
problem.
Sheena.
Hi. Sorry, I don't know if I'm late or not, but no, we're still waiting on other providers. I left the door open, so I've got one of the kids in here.
Hello, welcome.
Hi, Dr. Jen.
Oh, hi.
Thanks for joining. And I think we have Sheena as well on the call with Tila.
Okay. So we're just waiting for maybe Dr. Boudouin already here.
I didn't see her on the floor yet, so I think she might be coming in from her office.
Yeah, okay.
She knows about the meeting, so she's just probably...
Yeah, maybe just a few minutes late.
So we'll just wait a few minutes for her to show up. Hi, Dr. Jen. I'm Doug. I'm one of the clinical informatics specialists. I'm going to be doing the physician portion of this session here today. So I think that what I had planned was just, I'll go through a few slides, just sort of a recap of what we can do in the system and what I'm going to talk about. And then I'll go through a short demo. So it'll be about 20 minutes, maybe 25 minutes, depending on how fast I go through it or how slow we go through it. If you want to stop me at any time and ask questions, that's fine. That's what we're here for. And at the end of that, at the end of the demo, we have about 10 or 12 questions specifically for you as well. So
Dr. Boudouin just joined, so
just joined.
Yeah.
Okay.
Yes, I'm here.
Awesome. Okay. So hello, I don't know if you caught that. I'm Doug. I'm the clinical informatics specialist that's just going to be doing the physician portion of this session here. So welcome. Thank you for joining here for this hour, and I look forward to some good discussion, hopefully. So I'm just going to get going here. So these first few slides are essentially just going to be a recap of what I'll go through the demo in a few minutes here, just what the Cerner system can actually do for you. So this first slide here is just the provider. So when we're saying provider, we're assuming anyone with ordering privilege, so physician, nurse practitioner, midwife. So this is the assessment and documentation. So this first portion here, because you are doing triage of the clinic, would be accept or reject referral, and I'll show you how to do that a little bit later. We'll go through the ambulatory organizer, where you can see essentially your schedule for the day or your slate. So that would be like the replacement for your paper slate, and you can see everyone for the day, why they're there, how long the appointment's going to be, just a brief recap. You can enter lab diagnostic orders and like the diagnostic stuff that's going to route over to a different queue to get scheduled. So, CT scans, all these other sorts of diagnostic tests that you might be scheduling. You can document using the front-end speech recognition, and we've got a bunch of different templates and stuff as far as your documentation. And the last thing here would be the consultation notes. These are going to be distributed through Acceleris to the various downstream systems. So we can go to the next slide here, which would be the procedures and treatment slide. So there's lots of different various pre-printed orders for procedures, and you can bundle up any of the pre and post care required. The documentation, you can do it through interactive view or dynamic documentation using a procedure note. So I'll go through a little bit more in depth what that dynamic documentation entails during the demonstration here. And as well, so the consultation notes and the procedure notes within Cerner are the ones that are going to be distributed via Acceleris. So just to take note of that. And yep, next slide. And the last portion here, just follow-up patient departure. So you can easily create follow-up orders as far as any labs or diagnostics you want done after the appointment. And yeah, again, that's going to route to scheduling clerk to be booked. You can easily schedule follow-up appointments within the clinic, but it doesn't sound like that is too common. A lot of that would be scheduled over with the lung health center. It sounds like there is a checklist for discharge if you wanted to use it, as well as discharge summaries, but it sounds like you would mostly just be sticking with your consultation notes and history notes at this point. And just a last little note here, if the patient did come for a one-time appointment, you don't need to go through the process of discharging or doing anything else like that. They actually will just be automatically discharged from the system at midnight. So I'm going to actually get into the demo here and share my screen with you. Can everyone see that there okay? I'm gonna assume yes. Okay, so essentially this is what the power chart looks like, and it basically is what you're going to be using as the clinician. So you can look at all your documentation there, you can look at your labs there, you can do all your documentation there as well. So hopefully it's including everything that you're going to want to do when providing patient care. It is quite flexible, so there's lots, especially with the physician role, there's lots of different ways that you can do things. So I think it sort of gives you the opportunity to find what works best for you and stick to that, because I know not everyone's going to be wanting to do things exactly the same way and the exact same order. So it does give you some optionality around there. So just before we get into a scenario, which is what I was hoping to do today with you, we'll just take a quick look. I know there's lots of buttons on the top here, but just what I want to show you today and highlight today is first the message center, and then these other two tabs over here, which are the ambulatory organizer, which I did mention is just the schedule or your slate for the day essentially, and that's what you would enter the patient through on the day of the patient visit, as well as referral management. So if there is triage, which it does sound like is done on Fridays at your clinic, this is where you could see all the new referrals to the clinic, and they're going to populate there. So I've just opened this under respirologist physician account here, and it defaults you to the message center. So briefly on message center here, it gives you results, orders, documents, messages. You can send reminders to yourself if you want. You can go over to pools here, and you can see that it's displaying the last 30 days, and the pool that this account is under is bronchoscopy providers. So if you did want to do any clinician to clinician conversations, things like that, this would be the place to do it. Just the last note before I move on is this isn't meant for anything urgent, so that would still be done through the phone or whatever mode of communication you have decided up until that point. So from there, I'm just going to move on to the next portion here, which would be referral management. So I think what I was hoping to do was just go through a scenario, as in you're imagining that you're sitting down on Friday and you're going to triage some referrals. And I'm hoping to just like take you through a patient, what that might look like, and then stop halfway and then imagine, you know, a month later or however much longer you wait, that you'll actually go to the day of the appointment for that specific patient. So I'm just going to open up referral management here. It's going to load up preferences. So this is where you could screen all your referrals. And if you look here, you can see that I have all these filters already preset. So I have the location, Pacific Lung Health Center. This is kind of just what we've based the workflow off. So obviously this would be a different location. In your case, referral status, we have ready for screening here. It could be ready for triage. There's many different ones, but for today's purposes, we'll just leave it as ready for screening. Medical service, respirology. We're going to tumor group is not relevant to you. If there is a triaging priority that you're using within the clinic, this is something that you could fill in as well. And if there is referrals to specific physicians, this is something you could filter it by as well. So I have these filters. So we'll just have these three: rest, ready for screening, and location. And I can run the list based off that. And that's going to populate the new referrals that are ready for screening. And one last note here is that you can save a bunch of different views to yourself. So I have a triage one here, and if I wanted, I could run that. It's the same. So if you have different clinics that you're working at, you could build up your own lists there, what you prefer, and just go back in at any time and click them to run the referral. So from there, you can jump right into the patient's chart. So I'm imagining if you were in the current system, you're sitting down, you've got a stack of papers. Here's your stack of papers, and I have this patient here, RIU clinic demonstration. I'm just going to click once, and it takes me right into the patient's chart. So briefly, before we go any further, so we've reviewed kind of the main buttons that I just wanted to touch on today: message center, ambulatory organizer, referral management. I wanted to go over this banner bar. So it's pretty intuitive, most of it. So you have the patient's name, allergies. Something to note in Cerner specifically is that if you go to enter prescriptions, medications, things like that, it's going to give you a pop-up if the allergies haven't been reviewed with that patient encounter or no one's documented them. So you can go in and click right there. And if you wanted to review the allergies, there's no known allergies for this patient, click OK, or you will get that pop-up later on. Most of this here, pretty self-explanatory. I just want to draw your attention over to ENC type, which is encounter type. And that's just something that we're using in Cerner specifically. And that basically just bundles together all interaction, like it bundles together an interaction with the healthcare system and the patient. So that's important, especially as the ordering physician, is that a lot of stuff is going to float between encounters. So like the previous documents, labs, microbiology, all these sorts of things are going to float in between, but the orders are going to stay with that specific encounter. So if you were ordering stuff on the incorrect encounter, it may not get noticed and kind of it'll get lost. So that would be right there, encounter type. You can see this patient has a few different counters that I've put in there. We will move on from that for now. This menu bar on the side over here, I just want to draw your attention to these 5 on top. It's, again, provider view is what we encourage every physician to use. And this one is, you can really customize what you want to see. So if I click on this plus here, it gives you these pre-programmed options, and they're all going to have a different default setup. So, and even within those setups, they're all going to have different tabs, which you can see on the side. And if you wanted to at any time, you can change around, add, subtract, all these sorts of things. So we're going to come back to provider view. I'm going to click through the rest here. So results review, you can look through lab. If there's a head to toe done at when they're admitted, you can look here and that would pop up there for you. Orders, you can look at any old orders for this patient. Medication list, their current medications. So you can see I've popped a few medications in there, Atrovan, Ventolin, morphine. And then look back, and there's also this documentation section here as well. So, and of course with the documents, you can filter it however you'd like in regards to searching by profession, searching by date. You can search your own documents. You can search another specific person's documents. But from there, we'll go back up to provider view. So like I said, this is really custom. You can add as many things as you'd like or as little as you like. So I'm just going to imagine you've opened this patient's chart. You just want to quickly, whatever your referral triage process is, I've made a tab here just for our purposes here today, where I have the documentation at the top. Again, if you want to add or subtract whatever you like in when you would be triaging referrals, that is, again, it's totally up to you. So I just have some documentation at the top. Maybe I'll give this one a click. I can see a note. So this patient was seen in ER and then referred them to Respiratory follow-up, and you're like, oh, okay, awesome. You look, labs, histories, whatever else you need to look at, you can click through there. And if you decide, yep, like this patient, they're good for the clinic, we're going to accept them, you can go over to the quick orders tab here. So this is a bunch of preset orders for the rest position. So power plans are essentially pre-printed orders. So just groups of orders all bundled together. You have prescriptions, labs, imaging, and diagnostics. These are all the common ones here. If you did want to search for something that's not on there, you hit your little blue and you can search for whatever you'd like in there and add it. You can also add as many orders as you like to. There is like a little favorite section. But for now, I'm going to imagine that we are going to accept this patient to the clinic. So Pacific Lung, this is just the standard workflow that we're sort of basing this off of here. But we would go triage. And when you click something, you can see it populates up there to your little shopping cart if I want to get rid of it just a second time there. So it is up here and I hover. So another thing about Cerner, if you're not sure what, we just say hover to discover. So I can see I have orders for signature there. I can open up my cart. And because it is a power plan, especially, you're going to want to actually modify the details because it's not just a straightforward order. So this looks very complicated, I know, but for our purposes today, I just want to draw your attention to these two at the top here. So you can accept referral and you can go through, and if you want to see them within 3 months, you can change to whatever timeline that you would like within there, and then take you down here to reject referral. So if they don't qualify, you can just click the reject, and down at the bottom, you can just take note of, here's some diagnostic tests, here's some other respiratory tests, overnight oximetries, all those sorts of stuff. If you did want to add something on at any point, you're not just stuck with this. You can add orders up here, add to phase. But for now, we're just going to say, yeah, it looks good. I'm going to accept this patient. So when you are confirming an order, orders for signature, and it's going to give you a second chance to look at it. So I have two pieces of this. It's change attending to, provider none, because we're just referring it to the clinic in general, not a specific physician. And the second part here is just saying the timeline within 3 months. So I can go ahead and sign that if I'm happy with what I see. And that will be into the system now. So if you wanted to, you could take a look over in your orders section, and you're going to see that your order is complete and they're accepted. So just to tie off that line of thought for the scheduling portion, that is where it's going to update in the PM office and show that this patient is going to be accepted and they're ready for scheduling. So at this point, I'm going to imagine that this patient's accepted, I'm putting the chart away, and I'm going to close the chart and go back to my home, and the patient, and I'm imagining, like 4 weeks later, 2 weeks later, whatever it may be, you're coming in to the clinic that day and the patient shows up. So this might be a good opportunity to, if you do have any questions at this moment, maybe I can answer them, or if you prefer, I can just continue on to the day of appointment, and that'll take me about perhaps 10 more minutes to complete, and we can go from there.
Well, I guess I had one question. So in our respiratory ambulatory unit, the triage is mainly done by the fellows. And I'm just wondering, is that possible? How would that work?
Yeah, that should still be fine. We would just have to make sure that they have access in that regard to the Cerner account. But when you're setting up these filters in the referral management, it shouldn't be a problem for them to set up those same filters to access the same list that you'd be able to access. Does that answer your question?
Yeah, it does. And then when they enter to triage, in theory, there's like a supervising attending that's there to kind of help them if they have any questions. So do they enter their triaging order under an attending or just under their own name? I'm just curious.
Yeah, I must say I'm not quite sure on that. I think that would be more of a your own practice thing. If you would normally have to co-sign or whatever, I'm not quite sure. So I might have to take that one away. But either or is possible.
Yeah, just to help you out there, I think a fellow can there's no Cerner limitation. If they if it's accepted within your practice, they could just place the accept order and the system wouldn't prompt them to put in an attending. But if they wanted to do that because that's your practice or whatever, then we could look to facilitate that as well.
It's Rachel. Okay, thank you. In follow up on that, we also have a triage form. So I wonder whether we should have something like a power plan, like PHC, to help us streamline our triage rather than use the standard quick order. Can I share the screen to show you what we have and see whether you have an easy way to do that rather than create a power plan?
That's okay.
Okay. I think I'm disabled to share.
Oh, okay. I'll just stop presenting now.
Okay, I can share screen. So main thing, I just want to show you this form. So this is our current triage form. I don't know, can you see it?
Yeah, we can see it.
Okay, so we have the data triage. You see, you can triage by fellow, and there's a supervising staff assigned for the triage for that week as well. So that's a workflow. And then usually that will be three options, either appropriate for RU, redirected to lung center, or redirected to BCCA interventional respirology group for lung cancer related diagnostic and evaluation. And then we have a triage kind of urgency to let the booking person know to book this into our RU. And then this is the investigation we want it to be done sometime at the same day or before the appointment. So I know this is can be in a quick order, but I just wonder for this part whether there's an easy way for us to do that and communicate easily rather than go through a quick order.
Yeah, I think I can't promise any solutions or lack of solutions right now, but just if you or Tila can send us this form over, we will review it and do our best to come up with something that suits you. And then when we meet again, we can discuss it a little bit further.
Sure, but isn't that what you did for the Pacific Lung Center? Like a power plant? It looks like the power
Yeah.
similar.
Dr. Jen, it's very similar, but I have to say that Pacific Lung had a lot of additional complexity that we just because they would send referrals to specific individuals. Like you have here 3 different things that you could you could redirect a referral to, but they had, I would say, 12 or more permutations for who it could be sent to. And then they would, even within that, if it got sent to somebody and they disagreed, they could send it to somebody else. So I think that was additional complexity. I think Doug's right. I don't want to promise that we could do a power plan as well for here, but I do, I can think that we have some options that we can show you next time. I can already think of a couple ways that we could facilitate this.
Yeah, I just want a streamline kind of process for triage. I don't want to click multiple things for us to complete this. Yeah, so I will wait for your suggestion and see whether that will be suitable for us.
Yeah, I just want to
For
add
sure,
from a physician perspective that if we could have a power plan, that would be much easier and welcomed.
Okay.
So maybe a work. I think I can stop sharing now. And then the other question I have is that, for example, I guess the fax number for the RU will receive the referral, and then someone like Tila will kind of assign to the fellow and then to the staff for triage. Have we talked about workflow, or maybe that's what you're gonna do? Sorry.
Yeah, I think for that, so the workflow I was going to show you next was essentially like the day of appointment thing. I think later on we'll have to get more into the weeds as far as how exactly, because she does an initial screening as we understand it, and if something is very urgent, would bump that to you directly so they can get the process going. So it sounds like she is going to need some sort of access as well to do like a pre-triage screening. But that's a workflow that we'll have to, I think, talk about in some of the following sessions a little bit more closely to nail down exactly what is needed.
Okay. Okay. And then also, okay, so what are we gonna, so you have follow-up question for us to understand what we need?
Yeah, just a few here. I think what I was hoping to do first was like show you a just day of appointment thing, and then I'll just present here. Then we just have a few questions for you just to make sure that we fully understand what is needed, at least hopefully. If we're okay, maybe I'll just quickly head through like a day of appointment visit, and then we'll jump into some questions for you, as well as obviously the opportunity for you to ask anything else further that you'd like. Okay, if everyone's happy, I will continue from there. So we're just imagining it's that same patient. We've managed the referral. We've accepted them. They've been scheduled, and now you're coming for the day of appointment, and you would access that through the ambulatory organizer, which essentially is your schedule for that day. So you can see here, I've got January 20th. I can choose different days if I want to see what my work looks like for the rest of the week or following weeks, that sort of thing. And this important thing here is your filters essentially. So what I've clicked is Physician Donaldson, who has an appointment here with this patient at 10 a.m., as well as the resource group. So it's depending on your preferences if you just want to filter for yourself or you'd like to filter to see what, if any other colleague is doing anything else in the unit that day. But it sounds like it's just one of you working at a time, or maybe two. So, but that, again, that is up to you. That's sort of it for the ambulatory organizer. It's just going to give you what your slate is for the day, essentially. And I'm going to click into the patient quickly. We've already gone over most of the stuff. I just want to take you through the outpatient chart. So we're back into the provider view, and instead of the referral triage tab, I've chosen outpatient chart. These are some of the tabs that I've just set up here that I think are pertinent to just quickly buzz through. Again, you can see there's a lot more options here, but I've only checked a few. So patient info, this is stuff just getting pulled in from registration. Vital signs and measurements, if you wanted to take a quick look at that head to toe that was initially done when they got it taken in, you can look there. Links, this connects you over to Care Connect if you want to pull up any other info. Active issues, so this would be a place for you to add an issue, say you're draining a recurrent effusion, you would just go ahead and add that there. Histories, fairly self-explanatory. There's different segments: family history, social, surge history, and a lot of those will get pulled in as well if somebody makes a note in a different part of the hospital, like they just did a bronch or they've done this, it'll get pulled into that surgical history. Current medication, so if there's an outpatient, so if this patient, they would have some current medications on here, whatever they're currently receiving in the hospital. Home meds, I've got a few home meds pre-populated on here. There is one thing to note with the home medications, that you can go into meds history and external history up here. If you wanted to, you can import stuff from PharmaNet. It's not going to let me, of course, because this is not a real person. But if you wanted to import their home medications, you could do that there. You can take a look at the documents. I still have that ED provider note sitting there. Allergies, I've already mentioned that Cerner will prompt you if you haven't reviewed the allergies. Order profile, so you can see what's been ordered. There's some labs, diagnostics, follow-ups, referrals. And this would be the opportunity here, labs, micro. So if you ordered anything during the referral triage, you could take a peek at it here. Getting down to the notes section. So I did mention before that like the consultation notes here and the procedure notes, those are the ones that are going to get distributed through Acceleris. So it's going to open, maybe not the free text one, but the top one here. So this is just a pre-documented one, and it pulls in. So some of that stuff that's been filled in those sections above gets pulled in here. So when you are going through the chart, it's definitely a good idea to be just a good caretaker of the chart. If a problem is resolved, resolve it. If something new comes up, add it, and it just makes the documentation a little bit smoother as far as pulling in stuff to save you from typing and typing and typing. One other thing to note is you can build up your own documents and really just customize them to however suits your preferences. And the only other thing to note on there, I would say, is that if you have a colleague who you see their note and you really like it, you could go up to auto text copy and actually search them by name and, take a copy of their documentation templates for yourself and begin using theirs. So that's a bit of a handy little thing you can do there. I'm just going to discharge changes there. Okay, perfect. So we'll imagine that you've reviewed all that info. So all this info here, I'll just go back one more time. So like I said, if you do have a new problem, go ahead, add it. So update the active issues, update the histories, and all that's going to feed into these documents. So we'll imagine that you've reviewed everything, you've seen the patient, you've documented, and you're like, oh, okay, I think everything went well, but I want to follow up with this patient in 2 weeks. You could just go to outpatient quick orders. And again, outpatient quick orders, it's assumed that the referral or the order will be completed later. Whereas if you click over here, the quick orders, that's under the assumption that they're in hospital and that it's being ordered for right now. So if you wanted to do a follow-up, again, we have this set up from Pacific Lung. Essentially, you could go into outpatient quick orders, Pacific Lung follow-up, populates up here. You can open it. Again, you just need to modify and say I wanted to follow up within, 4 weeks. I can click there. And if I needed any diagnostics, you can select that there as well. So just for simplicity, we're just going to say 4 weeks. Orders for signature, like I said, it gives you a second chance to look at it here, and you can sign from there. And now that order is in. And like I mentioned before, if you want to add any favorites, any things like that, where it's not pre-programmed here, you can go ahead and do that. That's more or less what I wanted to show you. So it's kind of the process as we've imagined it, as far as like a patient gets referred, you triage them, everything looks good, you accept the referral, and then, however much longer later, you enter the patient through the ambulatory organizer. You choose whatever tab that you've set up. In this case, I showed you the outpatient chart. You've documented and you've ordered for a follow-up at a later date, and you've chosen that length. So that's essentially my demo there. I'm just going to stop presenting, unless you'd like me to click on anything in particular, just to see before I stop sharing my screen here. Okay, I'm just going to stop sharing that.
I just have a question. So,
Yes.
For example, we will receive referral within the hospital and outside the hospital. How does it look like when we see them in the referral manager? I know you show me all the relevant information, but I'm just used to seeing a form or referral form. So what will I see in the CST for those referral form from outside?
Maybe I will just we can jump back into just for a moment. So I'm still in that patient chart there. So this is, if you're asking what information that you'll see when the referral populates this list.
No, I'm asking, for example, we have a standard referral form, like for RU, and then usually, for example, the family doctor filled it in manually and then fax it to us, and we will receive, I assume you will have a PDF file, so I would see that form somewhere.
So that form, so This is
So
sort of a
maybe
little.
I can answer your question, Rachel. So because I do use CST at BC Cancer, and so if it's coming from elsewhere, so if it's not somebody that's using Cerner that's giving you the referral and using the paper form, it's going to be a PDF inside the documentation part of the chart of the patient. So that's one of the first thing you're going to see is going to be called like referral package or something. And then you click on it and you kind of see the note of the patient with all the, like if they send a CT scan report and like PFT report, and everything's going to be like a scan in one package that you're going to see. If it's somebody that's using Cerner that's sending you a referral, then you're not going to have a referral package. You need to go in the orders, and then so you kind of look at the orders that they put, and then usually they put like, okay, I'm ordering a referral for respirology ambulatory unit, and the reason is I don't know, like interstitial lung disease, blah 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 blah. So that's where you're going to see it, but you're not going to have like a written document for the internal referrals.
Okay, thanks.
Yeah, so that's exactly right. So there is, so like if there was a referral package that comes into, it's more on the scheduling side, but comes into the working monitor and it gets digitized, and they would essentially just index it to the chart. So that whole referral package would appear here, and you can go ahead and like open it up. This isn't going to say much, but.
So it will be easy, very easy for me to know whether this person is from outside or inside. There's a quick way to look for it other than just checking the order and documentation.
Yeah, so I think yeah, all the external ones are going to be attached as referral packages, whereas the internal ones you're just going to see. You're going to see that there's an order and it'll populate, and like best practice, what we would recommend if you're going to be, entering an order to referring to the clinic would be for the physician to write like corresponding documentation with their assessment, saying like, I saw this patient and I think they're appropriate. This was the situation. And so you would hopefully be able to look at any corresponding documentation. So if they've been referred from ER, by whichever physician, you could see in the orders, hopefully that there should be a corresponding like consultation note that you could take a look at. So the external ones would be here as referral packages, and the internal ones would come through as an order, plus hopefully a corresponding consult from the referring physician.
Okay, thanks.
Obviously, Rachel, as well, when you're on the referral triage page, it's like you have the name of the patient, the age, and like where it's been referred, and then you also have who referred the patient. So so you have the name of the physician. So like if you know that it's referred by another respirologist or by a thoracic surgeon or by like a medical oncologist, like, or a family physician. So sometimes you just kind of know those names, and that's kind of quick to know where the referral is coming from.
Thanks.
Can I ask a question as well? So
Yeah.
Patients are coming to the respiratory ambulatory unit, yes, for consultation, but they're also coming for procedures. And so I want to make sure that we have kind of power plans that are going to be within the clinic to make sure like we do a lot of like chest tubes, pleurex insertion, pleurex removal, thoracentesis. We do some declotting of pleurexes. We even have patients that are coming for bronchoscopy. So all the pre-procedure stuff is going to happen in the RAU, and their post-procedure monitoring is going to be in the RAU as well. And I just want to make sure that that's going to be easy to access for these type of patients as well.
Yeah, so within Cerner, there is a lot of pre-printed orders. Perhaps we won't try to click through all of them right now, but I think like what we're hoping to take away from this session is a list of documents that you're most often using, and importantly as well, like what procedures that you're doing, because at some point, yeah, like we're going to have to look through what Cerner actually has and confirm what is available in the system. But I think unless you're doing anything very rare that is not being done anywhere else, that we should have pre-printed orders to address most procedures that you would be doing, yes.
Um, it's Rachel. So I'm actually doing the quick order review. So you, me, and Sheena can review the procedure that's done at RU and making sure we have request those to be added to the quick order to suit our need as well.
Yeah, that'll be great. Thanks.
Yeah, we'll have to go through and see which ones are missing and if we are able to add them or not. But I think that's something we'd have to take away. Alex, do you have any thought on
Hey,
that?
sorry. This is Fraser from the provider experience team. I had been working with Dr. Jen back in October to do those quick orders, and I was just going to jump in and say that I know that she had provided a list of power plans that we've passed on to order sets, and I think after CW they're going to work on those. But yeah, any of the quick orders communication can come back to me.
Okay, thanks, Fraser.
I'm just doing a quick time check. We do have 19 minutes, and I know there's a number of questions, so I'm wondering if we can maybe start with those and then come back to questions after.
Does that sound okay?
Yeah.
Yes.
Yep.
So just a few, we have about a dozen questions for you here. If we've already written something down, we're just asking hopefully for you to confirm that we have the correct information. So do you have standard documentation templates? If yes, what are those? We have initially consultation notes and history sheet. Do you have anything beyond that?
No, it depends. Nope. Like we have like consent forms and like those kind of things, but otherwise for documentation of the consultations per se, I think that's it.
Okay. Do you have any letters that you give to patients? We have this as a no currently, so nothing like that as far as like I guess pre-appointment or post-appointment. There's no letters given.
Well, that would be something that could be discussed with Sheena, because we do have some handout, like bronchoscopy handout, pleuresis handout, like those kind of things. I don't know if that's what you're talking about, but like, yeah, if there's some printouts that we can give to patients, is that right?
Yeah, that's along the same line. So just like educational materials. Yeah. Okay. That's good.
I think we're kind of alluding to, I guess the first question is around like templates. Like, are all the providers in your clinic using the same, I don't know, template for the same, kind of treatment or visit? Because some groups have standardized documentation, and some groups, every physician does their own thing. And then piggybacking off of that, I think when we talk about provider letters, it's like if you need a sick letter for the patient or like something like that. Do you just have like a standard one for all RAU patients, or does every provider just do their own?
Yeah, it could be useful to have a letter. And the other thing that we document quite a bit in the RAU is procedure notes as well.
Okay.
And everyone uses their own like free text kind of thing?
For procedure notes, well, I personally use the OR note that you have within Cerner.
Oh, okay. All right, thanks.
Okay, as far as dictation, how are you dictating right now? What systems are you using? You're all just like, are you just using paper or?
So no, most people use either the phone system or Fesser right now.
Okay. Just a quick or do you send a copy to other providers involved in the patient's care of your documentation?
Yeah, so if people are using the phone, they just say it on the phone, and then otherwise on faster. They just need to add the providers.
Okay, thank you. What medications, labs, diagnostics commonly ordered by providers in your clinic? I'm assuming this is probably a large list that we might have to get from you later on, but there's a few that we have there.
Yeah, I think there's probably a long list indeed, because there is a lot of ILD patients, there's a lot of bronchoscopy, so that might.
Okay. So do providers within your clinic share responsibility for reviewing and managing patient results? No?
Yes.
Yes.
So I think the current system, for example, when the patient triage, we assigned a fellow and attending to review it, right? And often, for example, the CT scan, which when it's ordered, is actually being copied to that ordering physician, and then but the appointment may not be scheduled to that physician 2 weeks later, 4 weeks later. So I think there's some shared responsibility for reviewing and managing patients' results.
Okay.
How does the physician who actually sees the patient, I guess they just look up what the results were?
Hi guys, I can add something to this. So how I book actually is with the CTs, if it's before the consult, I'm going to figure out who the provider is that I'm going to book them with, and then I would put the CT under that provider now. I know Levy used to do something different, but now that's how I and Austin have been doing it. So the provider should get the requisition for the consult.
Okay.
Yeah, that would be ideal.
Tila, are you just handwriting that on the requisition?
I do, yeah, and I handwrite all the requisitions, fax them, and then I upload them into our iClinic when I'm done.
Okay, thank you.
But again, still, I think when it's triage, someone is going to be triaging with the fellow rather than the physician scheduled to see the appointment, at the appointment.
It's true. What I've been doing, though, is just getting the fellows to just fill out the triage and not do the requisitions. And then I'll write the requisitions under who I book the doctor or book with.
Well, I don't think that makes much sense, Tila. That's a lot of work for you. Like
that's what Austin and
what we're gonna ask the fellows to do is to triage, and like if they need PFTs or CT, they're gonna order that. Yeah.
Yeah, I've been doing it recently, so just a heads up.
No, that will be helpful because sometimes I think it's a lot of work, yes, but I do feel it's helpful. Sometimes I see a CT scan popping like in my mailbox. I don't even know. I have never seen this patient, and at the end, usually it's a RAU triage kind of CT scan.
Yeah, but Rachel, it's going to be an order in Cerner now. So like Tila will have to go back in the orders and change the provider. Like it's not going to be like a paper order anymore. So other than like the fellows don't put the orders in and ask Tila to put the orders in on her own, which doesn't make sense. The fellows are going to put the orders in, and then we just need to make sure that CT scan is, I don't know under who, but yeah.
We can make it so that I can follow up with the CT scans too once I know they've been ordered, and then I can just flag the provider. That could also work.
But the fellow can order the CT scan, but a staff's name has to attach to that CT, right? Because you cannot expect the fellow to follow those CT results.
I know that.
Yeah, so somebody has to be attached to that CT scan when it's ordered. So what will be making more sense? I think what will make more sense, like you said, it's probably whoever assigned for triaging that week should be a copy. And then maybe, I don't know whether there's a way after Tila figure out who will be seeing this patient based on the schedule and copy to that physician. Would that make sense, or would that just be too much work?
That would work for me if we're able to do that.
I think more to come from a CST Cerner perspective on that one. I think that there are some options that I've seen in other clinics that we could talk about, but maybe in our next session, if that's okay.
Okay.
Okay, so moving on, a few more here. Do you ever direct admit patients or transfer them to the emergency department? So I'm under the assumption this would be potentially an outpatient that comes in, or somebody who's come from the ward, you've done a procedure, and now they're actually needing to go to, I guess they would be transferred to emerge, but any outpatient?
The answer is definitely yes.
Yes.
Yeah.
Okay.
It doesn't happen very often, but it does happen.
Okay. This last one here, any other specialties, clinics that you commonly refer to? We just have these two on here for the moment.
I think I think one of the thing I was mentioning in the triage is that we commonly refer to PCCA, the interventional respirology group, and then we will send this referral to like lung center, which is outside of the RU, but the same provider. So that's like the common specialist that we refer to. Yeah, thoracic surgery, ENT.
Can we add the asthma educator as well in there?
Yeah. Or pulmonary rehab.
Okay, because I'm writing these down. So.
Okay, we can go on to the next slide then. So do you usually conduct a medication history as part of your visit via PharmaNet?
We always conduct a medical history. Is yeah.
Medication history, yeah. Okay. Good. Do you actually go through a formal medication reconciliation as part of the visit? Or
no, but it could be nice to have that opportunity. Actually, that would be good.
Okay, we'll make a note of that. Common prescriptions that you might order in the clinic, and are they provided on paper or faxed to a pharmacy? So obviously this would depend if they're going out to the community or within the hospital still, but.
No, I think it can be both. We have an EMR, and just recently TILA has, our EMR is iClinic, and TILA has been adding the patient, just like CST into iClinic. So now we can actually order prescription and send it, fax it directly to pharmacy through the EMR for the RU patient as well. And sometimes we do provide a paper prescriptions patient is prefer, or the physician is prefer that way.
Okay.
And then about this formal medication reconciliation, I just don't want it to be super complicated, like the inpatient admission, medication reconciliation.
Yeah, I mean, I think it's more of an option for you. So it would be.
Okay.
Yeah.
It will be good. I don't know if I've done much of admission, but sometimes the admission, maybe for bronchoscopy sometimes, but it seems to be a little bit complicated for the formal medication reconciliation from CST point of view. So I just want to make sure it's not like mandatory, and if some people prefer not to do the formal one.
I totally agree that it shouldn't be mandatory, and we should just have it as an option, especially for the future. Right now, I don't want to add more work for the nurses, but at the cancer agency, our nurses are doing all the medication reconciliation before seeing the patient, and they're taking the vital signs, and then we're seeing the patient. So that might be something that would be nice to have in there, so as an option in the future.
Okay.
Yeah, we'll take a note of that. If they require a new prescription out in the community, who would be completing the refill?
It depends.
Okay.
Sometime will be the GP.
Okay. Okay,
What
but
do you mean for control prescription?
are they treated any differently for you when you're prescribing and sending these patients home, or is it no difference?
So, for example, are you talking about like a triplicates kind of narcotic medication?
Yes.
We have to use a paper form, isn't it?
Yeah, not with Cerner. We can do it on Cerner, and it's going to print on some kind of triplicate paper with the print form. So the answer for you is no. So right now what we do is we have paper triplicate and we give that to the patient, and obviously we can't refill that over the phone or faxing. So the patient, if needs more, will need to go see their GP or like see us in follow up or something of that sort. And the other new prescription that we usually give, we also usually give them paper, but we can phone the pharmacy sometimes or fax it to the pharmacy. So it's the same for either the triplicate or the other prescriptions, I guess.
Okay, thank you. Standard appointment times for providers, if yes, what would those be?
So there's currently no standard times, but I do have a list of provider preferences of what they like, and I try to book them according to their preferences. But essentially, clinic is open 8:30 to 4:30, so they kind of get booked anytime, mostly.
Okay. Does your clinic participate in any patient rounds, case conferences regarding any patients coming through the clinic?
No.
No. Okay. Just clinic's processes for billing.
We bill separately for physician.
Okay.
Are you using iClinic for that right now?
I think everyone's different. I personally use iClinic, but everyone have different billing practices.
Okay. Is there anything required from the RAU, like in terms of providing physicians with like a monthly summary of which patients they saw in clinic or something like that?
No, I just usually will give the physician a patient label, and then everything is charted in iClinic as to what was happened during the RAU visit. So the provider can just look up the patient, and then everything is all there.
Yeah, we just need to make sure that on the label we have the name of the patient, the full name of the patient, the date of birth, and the PHN number. If we can have the referring physician, that makes our life even easier as well on the label. But otherwise, those are the only three information we need.
It will be nice if we can just print out, not monthly. I usually do billing weekly, so preferably if we can do like, if I can have a quick report to say, okay, I have seen this patient in the RU this week, and then I will just print it out and give it to my biller. That would be awesome.
Yeah, I think those already exist, what you're describing. So we'll show you next time. Hopefully it will work.
Great, thanks.
So this is the last slide of questions for you here. I'm just looking at the time. We have 1 minute to go here. I think this top one, you could list off the procedures now, but perhaps like a more formal list, if Tila could send that to us at some point, just so we have a list of like all the procedures and treatments that are done in your clinic, just so we can actually look through and see what we have within Cerner already would be ideal. As we understand, procedures, treatments, so you'd be sending people down for bronchs, but all the other procedures you would essentially be doing within the clinic. Is that correct?
That's correct.
Okay. And we've already talked a little bit about documentation. You're essentially you're all sort of choosing your own notes. You might be using the OR consult note or free text, but you're all doing your own thing as far as documentation.
That's right.
Okay. Procedure notes, they will be distributed to other clinicians involved in the care. That's correct?
Yeah, absolutely.
Yeah. And post-operatively, do these patients follow up in your clinic? No, other than some of the pleural disease patients, if it's like a recurrent effusion, that sort of thing. Those would be the only ones that would be following up in the RAU clinic itself.
Yeah,
Okay.
and that's a lot of patients, but yeah, the pleural disease are definitely following up with us, and like the other like bronch patients usually not in the area.
Usually not. Okay. Okay. Great.
I just want to be conscientious. We're at time. I think we had 2 more slides of questions, but I think, I don't know, Tila, if you have like 5 more minutes, we could probably bang these out with your information.
Yeah, I've got time.
Thank you.
Thank you, everyone.
Yeah, thank you so much for attending for the rest of you folks.
Thank you.
Thank you.
Doug, are you going over these questions?
Yeah, I can go over them. That's fine. So these are just case conference ones, and I guess if you don't do a case conference, then we can skip this slide essentially.
Yeah, there's no conferences.
Okay. Okay. So that's easy. Gone. Okay. So next one, this is regarding just, is there any research, clinical trials, anything like that going on in your clinic where that sort of data is collected, logged, anything like that?
The only research we do is a bronchoscopy research with Dr. Carlston, and he actually has his own research team that will come in and they do all of the research stuff. I would just prep the bronch as usual following their orders. So that's the only research we do, essentially.
Okay.
So you don't, Doug. So you don't schedule or request these appointments, right? In your clinic?
No, the research team would contact me to schedule and request them.
So you would be scheduling?
I would be scheduling, yeah.
Okay.
Okay, so you would be scheduling. You are scheduling clinic appointments purely for research. Are there, again, I guess the standard appointment times, you would be the same sort of answer you gave us before, just whenever it fits in, or would Dr. Carlson have specific times
so for Dr. Carlson, it would be whenever works for his schedule, and then a bronchoscopy is a 4-hour procedure, so I'd just have to have a clinic bed for 4 hours.
Okay. And that 4 hours is like the pre-proceed, like they're showing up at RAU, you're doing all the check-in, they're going downstairs, and then the end of the 4 hours is they're recovered and leaving at that point?
You got it.
Okay. So would you be communicating the appointment information to these research patients, or would that be done through?
That would be done through Dr. Carlson's research team. Okay. They actually even pick up the patients and they will drop them off for the procedures.
Okay, great. Thank you. Anything unique at the bottom as far as scheduling or exceptional workflows? I think we got.
No, exactly the same type of scheduling as before.
Okay, awesome. So any other like standard clinic or operational reports that you're using in the clinic?
Just mostly, again, our triages and then our PPOs for procedures.
Okay. So in downtime, if case is down, what was the process for capturing any patient information? Are you just documenting on?
I would just document on my nurse's notes and then handwrite everything out.
Okay. What information would be back entered?
So like just any vitals or anything that kind of happened in clinic if there was downtime.
Okay. And is there any documentation to indicate that this stuff that you're back entering was actually performed during downtime, or is it just going to be that the piece?
No, there's never anything.
Okay. Do you have any existing downtime processes for?
No.
Okay. You can go to the next slide. I think that might be another opportunity for you to ask us some questions if you have any.
No, none at this time.
Okay.
Just wanted to confirm regarding the reports. There's no like Ministry of Health reports or finance reports from like a hospital perspective that you guys use, right?
Not that I currently use. I don't know what the physicians use.
Okay. I wonder like for your manager like Lynn, like I wonder if there's anything she requires from like an operations perspective.
That unfortunately I do not know.
Yeah. Okay, no problem. Thanks.
Thanks, Tina and Alex. We're wrapping up our session here. So the next steps would be like we would like to have the forms which you mentioned, Tila, or the screenshots of the templates of the nursing notes or whatever you document.
Yeah, I can email over a package to you of all the forms we have.
Okay, thank you for that. And our PDS engagement team is already in touch with you and the providers from this clinic to set up another session, the follow-up session for February 3rd. And after that, there will be one more session. So our aim is to like to demo you the future state workflow and validate like whatever we would be able to build by February 3rd. Or if like based on the requirements we gathered today, and if we do have any additional questions which we would like to have more clarity on, would be asking you.
Yeah, you can either call me or email me. I'm here every time.
Oh yeah, definitely will follow up with you. And there would be one scheduling session in which they will dig deeper into all the details they require. So that date has not been decided yet, and but soon you will get the invite, and the PDS team will be in touch with you.
Perfect.
Yeah, that's all we have from our CST. Thank you
awesome.
For
thank you guys so much. I hope you take care.
Yeah.
Bye now.
Thanks, Tila.
Thank you, Tila.
Bye.
Bye.